Great pride, immense pleasure, and a deep sense of privilege that we welcome you to the 19th World Dental Sciences and Oral Conference and PFA Conference and Awards 2026. Centered on the inspired theme, Bringing the Future of Dentistry, Now and Beyond, this prestigious international forum is organized by Pavitra Academy, Section at Large, Asia Region 9, in academic collaboration with Maharashtra Dental College and Cynodent International. As we gather today, we celebrate not only the scientific advancement and academic excellence, but also the spirit of innovation, leadership, and service that contributes to transform the profession of dentistry across the world. May this conference serve as a platform for learning, collaboration, inspiration, as we collectively envision the future of oral health care. I request our first speaker of the day, Dr. Sumit Goyal, to enlighten us on the topic, Management of Oral Mucosal Lesions, Current Concepts and Recent Trends. For moderating the session, I would like to call upon Dr. Ashish Chandra. Dr. Ashish Chandra has Masters in Oral Medicine and Radiology and has received Certificate in Dental Implantology from UCAM. He is President of Indian Society of Dentistry since February 2022 and co-director of Cynodent International from December 2020. We welcome you, sir. I request you to kindly introduce the speaker.
Good morning, everyone. I am proud to introduce Dr. Sumit Goyal sir, a proud alumnus of Subharti Dental College. Dr. Sumit Goyal sir is currently Professor of Oral Medicine and Radiology in Subharti Dental College and Hospital, Meerut. He is President General Secretary of IDA Meerut Kent branch. He is also mentor in BDS to MDS NEET Preparation Institute and Chief Clinical Consultant at Science Care. He is past alumni president of Subharti, Swami Vivekanand Subharti University and Chief Administrator and Admission Coordinator of Subharti Dental College and Hospital. With more than 80 publications and more than 1,000 citations, he is National Course Mentor for Associate Fellowship in Lasers Dentistry in academic collaboration with Northwest International University. With a teaching experience of over 16 years, he has authored oral medicine and radiology chapters in NEET preparation textbooks. He has been DCI inspector to colleges as well as guest speaker to various national and international conferences. He is the recipient of Sushruta Medicine Science Award in 2022, Best Researcher in the field of oral medicine and radiology at King George's Medical University in 2022, Magnificent Oral Medicine and Radiologist of the Year in International Dentistry Awards 2023, and for outstanding contribution in oral medicine and radiology 2024. Recently, he has been awarded as Dr. S.P. Agrawal Recognition for Active Branch Secretary General of IDA Branch in 2024 and 2025. His keen interest includes medical management of oral lesions, orofacial pain management, and maxillofacial imaging. We welcome you, sir.
Thank you so much, Dr. Ashish. Am I audible there? Those who are sitting at the back seats, are you able to hear me? So, thank you, Dr. Ashish, for that formal introduction. But my introduction is that I am the family member of Dr. Anmol and Dr. Ashish. It is an honor to be here because it is always, whenever these conferences are there, I am invited as the guest speaker. And thank you so much once again for this honor. And yes, I am Professor of Oral Medicine and Radiology in Subharti Dental College. And yes, I am also a NEET mentor for students who are preparing for. Can you please change the slide? So 2 days back, the results have come. And these are my students who have got all these ranks, 12, 20, 34, 52. So I am a proud teacher for these students as well. And I stand here today presenting a lecture for you all on the topic, please change the slide, medical management of common oral mucosal lesions. Now it looks very simple that oral medicine के हैं तो बहुत simple antifungals, antivirals. I'm going to tell you today the current concept of how to manage these conditions in your clinical practice. I am not here to offend any specialty, any medical specialty, किसी को भी नहीं. But yes, I am here to proudly uplift my specialty, which is why uncommonly called as a non-clinical branch, but I believe it is very much a clinical branch. So I will just talk about what I am doing as an oral medicine specialist. So can you go to the previous slide? So I just want to mention here about my mentor, Dr. Nikhil Srivastav. Slide, please. Because of him, I get most of the opportunities in various colleges and in various places. So I always start my presentation thanking him. Next slide. I will show you some medicines, I will show you some cases, but I am not promoting any brand. It is just because I have to put those medicines, so I am putting it here, right? Next slide, please. So there are several cases, oral lesions, which we encounter in our practice. You will also encounter once you will do clinical, or you must be because you are doing your clinical practice. But many of these lesions, they are actually wolf in sheep clothing, which we do not easily diagnose. But then there are some lesions which are actually simple. They look complicated, but they are simple and they are sheep or dogs in wolf clothing. So diagnosis is the most important aspect. Once we make the right diagnosis, we'll quickly. Next slide, please. So I have few prescriptions which I have again. I am not doing it to embarrass anyone, but yes, please understand that dental surgeons are I should say we are so much special, like we are specialists of disease. Like medical doctors, they cannot diagnose or treat any disease, be it a medical condition which is affecting our oral cavity. For example, we've encountered several cases, like this is a simple papilla. You must be knowing it's a parotid papilla, which was misdiagnosed by an ENT surgeon as, able to diagnose anything. He said it is just a mucosal tag or a ulcer. Next slide, please. Similarly, I don't know how many of you know this, but on the plate we see an autoimmune disorder. It is pemphigus vulgaris. Next slide. Again, it was misdiagnosed by medical practitioners as a viral infection. Giving antivirals. Next slide. I don't know how many of you know this, but this is herpes zoster, intraoral herpes zoster affecting the palate. Again, misdiagnosed as, lichen planus or aphthous by medical practitioners. So I am just telling you here that as dental surgeons, as oral physician, ये सारी चीजें हम ही diagnose कर सकते हैं and we can only manage it. Slide please. But when we talk about the management, all of you who are sitting here will agree with me that in dental practice, most of the dental surgeons, they are writing for all these diseases either antioxidants. ये एक छोटा सा सर्वे हमने किया था, उसमें maximum dental surgeons are prescribing antioxidants. The others, अगर ऐसे कोई lesions आते हैं, they are prescribing either dologel, dentogel, hexigel or mucopain, most commonly prescribed drugs. Anti-inflammatory drugs are next prescribed. Topical steroids, some of them, who knows it, they are prescribing. But specific management, we are not doing. So I am not or dologels or hexigels, we should not prescribe. Because they have a combination of anti-inflammatory agent, anesthetic agent and antiseptic. We do prescribe, but in simple cases like, please change the slide. If there is any cheek biting, next. If there is any burn, or any traumatic ulcer like this. Here we can prescribe these soothing agents very nicely. But then we have some specific conditions where we need to treat them specifically. For example, the previous slide we should go. For example, this. So how many of you know what is this? Anyone, any of the student who is sitting here want to diagnose what is this? But anyone who would like to make the diagnosis for this? No. So I'll tell you. This is a simple case of allergic stomatitis. Oh, next slide please. आप बाहर जाते हैं, आप समोसा खाते हैं, आप चाय खाते हैं, तो all these Chinese food or samosas जो हम खाते हैं, उनमें कुछ ऐसे constituents होते हैं because of which allergic reactions do take place and we develop allergic stomatitis in the oral cavity. Now simply, agar allergic stomatitis hai, and if we just apply these soothing agents, then it is not going to heal fast and the pain and this discomfort will persist for long time. Treat this. For this we need to have anti-allergic agents, so we can very happily prescribe cetirizine hydrochloride. We can give this mouth rinse, that is benzidamine hydrochloride. I'm sure all of you must have heard of it. It is not a mouthwash, mouth rinse having an anti-inflammatory agent, that is benzidamine hydrochloride. And this benzidamine hydrochloride we prescribe before the 3 major meals, and when the patient eats food, that burning, that pain that patient is suffering, it decreases. Apart from this, this Benadryl cough syrup, you must have heard of it. It is again diphenhydramine, that is anti-allergic. We can give it mixing with water, swish, and this is again very helpful in such cases. Next slide. It is there, so I can do that. Thank you. Well, all of you, till the time the slides are there, just understand that this presentation is important from the aspect of not from your curriculum or anything. This is from the point of view when you are already practicing, they will understand the importance, and this is why I am doing it today. So I will just move on to the next slide. इसी से change होगा ना? This. Don't worry, I'll do it. So next slide we can, because time is this. Next. So most of us as dental surgeons will encounter the cases of xerostomia. But then when we encounter the cases of xerostomia, trust me, this is the most difficult situation, because it is very difficult to treat patients who have got xerostomia. They'll keep on coming to your clinic telling that we are having xerostomia or wo theek nahi ho raha hai. And when xerostomia is there, it will lead to several other secondary complications related to it. Next slide. So in xerostomia, we usually do have that kind of shiny tongue, but this is how we basically, at the basic level, we manage xerostomia. Either we give those sugarless chewing gums, salivary stimulants like, you all must have heard about pilocarpine. It is a drug of choice for xerostomia. But usually, systemically, when we give pilocarpine, so it is associated with side effects. Because वो oral secretions ही नहीं, वो body के और भी बढ़ाती है. So I have tried this in many of the patients. The eye drops, what we get, pilocarpine ophthalmic solution by ophthalmologist. Same 2 drops of ophthalmic solution, agar wo 2 drop we'll put below the tongue sublingually, trust me, the salivation drastically increase and it reduces the side effects also. Right, so same ophthalmic solution, 1% you can use, 2 drops sublingually once a day will improve salivation in the patients of xerostomia. There are other modalities like TENS therapy, you must have heard all those, but वो clinical practice में बहुत readily available नहीं होता है, but वो improve करता है. But these small things can help us in improving the condition of the patient. Next slide. We have artificial salivas. Most commonly, we all prescribe these artificial salivas. The artificial salivas which are available in the market are in the form of either mouth rinses or sprays or even syringes. Now, what to consider when? According to me and my experience, sprays, artificial saliva sprays better for instant relief. Rinses are better if you are using it at least 4 times a day. Lozenges are better if you are going in a meeting. Immediately if you feel xerostomach, you can chew these lozenges and you will find that your oral cavity is moist and saliva improves. Next slide. And when required, we do have to give systemic medications. So you all know pilocarpine 5 milligram is the drug of choice to treat xerostomia. Nowadays, civimelline hydrochloride 30 milligrams is used for the treatment of xerostomia, but we only medications when all those topical adjuvants or treatment therapies which we have given is not working. Next. I prescribe patients. So prescribing medicines is not going to help. You have to give a lot of instructions to the patients. Like you can see here, I have already mentioned, you have to maintain adequate hydration. Vitamin C tablets has to be given. Your room, how it should, condition of the room, and all those things. And I have given those pilocarpine eye drops lingually, salivary substitutes. Next slide, please. Sjogren's syndrome, or when the autoimmunity is associated with xerostomia, then we need to give different medications. Nowadays, if you search the recent literature, it's an monoclonal antibody, this belimumab and abatacept. These are recent the patients of xerostomia, specifically those which are suffering with Sjogren's syndrome. And trust me, as the stress is increasing in our life, Sjogren's syndrome patients hain. They are there. We just need to recognize them, diagnose them, and treat them. Literature clearly says that rituximab has showed efficiency in improving the salivary gland function, but not xerostomia. Literature shows that it improves xerostomia. So, abatacept shows promise in improving both xerostomia and this belimumab long-term improvement of salivary flow. So these drugs are given when the treatment which I told before is not working. Next. I don't know how many of you know, but of choice which is given in the patient or radiotherapy. It not only improves xerostomia, but also improves conditions like radiation-induced mucositis. Next slide. Now herpes zoster. I am not talking about herpes simplex. We all know how to treat cases of herpetic dermatitis by using acyclovir. But we should know how to treat herpes zoster, which is not uncommon these days. The stress is increasing in our lives. The immunity of our body is decreasing. Because of this, we are developing conditions like herpes zoster. Herpes zoster is unilateral. When it is involving the body and the face, it is easy to diagnose it. But intraorally, again, as I showed you the initial slides, even the medical practitioners, they are they'll misdiagnose it as either lichen planus or pemphigus because really सब एक जैसे दिखते हैं. But we should know as specific dental surgeons that intraorally herpes zoster lesions do occur. They are unilateral and mostly seen on the palate. Next slide. So if I give a simple prescription in a case of herpes, like nowadays, rather than preferring valacyclovir in herpes zoster 1000 milligrams at least thrice a day, we are giving it. Apart from this, we need to give paracetamols and adjuvants to maintain the associated fever and other symptoms. Next slide. We give in herpes zoster. Next slide. Famciclovir, if we start initially, whenever the patient comes to you, initial stage pe if we start famciclovir, then we prevent the most important complication that do occur with herpes zoster, and that is post-herpetic neuralgia. The patients, their lesions heal, but the pain persists. Herpes zoster is very, हमेशा बोलता हूँ कि वो घाव भर जाते हैं, वो दाग भी चले जाते हैं, पर वो so that is the condition called as post-herpetic neuralgia. But if we initially acute stage pe promptly if we start the treatment, we prevent this condition. Next slide. Also these days, Brivudi patients who have got acute infection of herpes zoster, it also is in preventing post-herpetic neuralgia. But जो लोग यहाँ पे clinical practitioners हैं, they must have encountered that 50% of cases actually do develop this post-herpetic neuralgia, and when it develops, we have to treat it with, of course, it's a sick pain. Next slide. So we treat it with anticonvulsants or anti. This is also important in acute herpes patients. You should give some plain occlusal dressings. These plain occlusal dressings, they are helpful in early healing, and it also stops replication and spread of herpes zoster infection. But gabapentin. Then patient आपके पास आके बोलेगा मुझे बड़ा लिथार्जी हो रहा है, मेरे को नींद बहुत आ रही है, but then we can't help it. Gabapentin, best drug to treat post-herpetic neuralgia. After 3 to 4 days, the patient will get accustomed to all this, and he'll even those drowsiness and those symptoms disappear. Apart from this, gabapentin ki gablin, it is also very effective, and you can also give amitriptyline, that is an antidepressant drug, 10 milligrams at night. Very helpful. कोई भी nerve pain किसी भी non-steroidal anti-inflammatory drug या opioid से कर नहीं जाएगा. You need to have these drugs. And nowadays we have topical capsaicin available for pain. I don't know how many of you know here. This capsaicin is derived from mirch powder का paste है. Very helpful relieving neuropathic. So अगर patient को burning है या फिर ऐसा neuropathic pain है, इसको apply करो. 3 मिनट के लिए तो patient उछलेगा because of course we are applying the chili powder. In the due course of सारा pain चला जाएगा. Next slide. Nowadays तो herpes zoster. Next slide. Sure, no one in this auditorium has not seen a case of lichen planus. When I was a student, हम लोग को अगर lichen planus का case मिलता था तो हमें लगता था कितना बड़ा. Nowadays, in my dental, every alternate day, I am getting a case of oral lichen planus, that too erosive type, and this is because of increasing stress in our day-to-day life. हम पहले बोलते हैं ना, it is more common in females as compared to males, but अभी ऐसा कुछ नहीं है, because females आजकल stress दे रही हैं, तो males lichen planus there. Very difficult to treat. Lichen planus और अगर treat हो भी गया, come back. First to come, last to go. We need to step by step treat lichen planus, खासकर erosive lichen planus, because it is symptomatic. Patient will have burning symptoms. So this is erosive lichen planus. I am sure everyone easily diagnose it because of presence of those striae and of a gingival condition, that is squamative gingivitis. I repeat here, squamative in itself is not a disease. It is a manifestation underlying autoimmune disorder. Don't need those gums. We have to treat the underlying lichen planus first, then itself it will disappear. So how basically we treat lichen planus? Of course, it's autoimmune with inflammation. Chronic inflammation requires steroids. So treat lichen planus. However, we need to be very careful while prescribing steroids. The students who are sitting here, please listen to me very carefully, because आप steroids मेडिकल साइड में तो बिल्कुल जैसे चने मुरमुरे होते हैं ऐसे प्रिस्क्राइब किया जाता है, बट यू डोंट हैव टू प्रिस्क्राइब स्टेरॉइड्स लाइक दिस. Steroids are prescribed, right? So you all know that when we prescribe steroids, patients' blood glucose level, blood pressure, everything raises because steroids do that. So we need to take medical history very carefully while we are prescribing steroids. The patient should be immunocompromised, not be hypertensive. Please remember, if and hypertensive, we go for topical steroid. Triamcinolone, acetonide, most commonly given. But just by giving this triamcinolone, we cannot cure the patient. The patient is having a lot of burning. So again, you need to have something which is in addition to this. For this, what we do, we give systemic steroids topically. And how do we do that? We have prednisolone dispersible tablets. You disperse it in water and ask the patient to swish and spit 3 times a day. There is very limited systemic absorption, but again, the results are very good. Similarly, what we do, sometimes you all have heard about this betnisol tablet, betamethasone. This 0.5 milligram tablet, you crush it and you mix it in Kenacort. That is that triamcinolone acetonide. And when you apply this, it will have added effect. So these are the things which we can do in patients who are highly diabetic or they are hypertensive. Right? We can also go for injections, like we can go for triamcinolone injections. But then steroids are necessary when you treat lichen planus. Next slide. And yes, if the patient is not diabetic or we can give systemic steroids. But whenever we give systemic steroids, please remember, students, those who are sitting here, please remember systemic steroids whenever we give in single morning doses. The recent edition of KD Tripathi Pharmacology indicate give steroid as a single morning dose rather than giving it in divided doses, because we have our bodily steroid production also going on. So at that time, the external steroids, they work best. Apart from it, do not give steroid for very long time. Do not give it for 2 months or 3 months, because again, what will happen? We'll develop that Cushing syndrome. Whenever we give too much of steroids, there is redistribution of fat that takes place specifically on the neck area and in the face. So ekdam moon face ho jata hai. And do not abruptly stop steroids. Why? Because when we take external steroids, our bodily production of steroid decreases. That HPA excess, it regulates every comes steroid produce. And if you will stop steroid, what will happen? Even the body is not producing that much of steroid. Externally, we are not taking steroid. HPA excess suppresses, and patient can go into shock as well. So very important, please give steroids in a proper format. Next. Nowadays, there are many skin creams which are more effective than triamcinolone, like metronidazole. But then giving it intraorally is difficult. We are developing literature says that in the market, adhesive patches are being synthesized which act as a delivery system for these. Next. This also I would like to tell you, because you should all remember this. This is one of the very important way by which we can treat lichen planus. You were talking about the time? No. Ashish, you just let me know when to stop, right? So this is oral mini pulse therapy, where what we do is we take betamethasone 5 milligram, and we are giving this betamethasone 5 milligram only 3 days in a week. Right? A very low dose and just for 3 days. So this is what we are doing is steroid as in the form of mini pulses. So we can give this for 3 months. For 3 days, we are giving 5 milligram betamethasone. Rest for 4 days, we are leaving our body. कि आप synthesize करो steroid. Again, next week, 3 days. Again, next week, 3 days. Like this, we can give steroids. So इसका advantage क्या है? We are giving steroids in lower doses, that too for a longer time. Relapses are less when we give this therapy in patients of lichen planus. Next. I need to stop. 9:30 is there. So these are some treated cases. Next slide. Nowadays, this is what we have also using injections of platelet-rich plasma (PRP). All I have heard about treatments we use हो रहा है. It is used in the treatment of lichen planus, OSMF very effectively. One thing also I would like to just show 1 more minute. You can please skip the slides. You can skip these slides. Next week we can just leave this. Actually, after this looks very, but difficult to treat. So I had all those slides where I could. If next time I'll get this opportunity, I will tell you how to treat such previous slides only. Here I would like to mention to all of you one drug which we have used in our department very effectively, and we have got prize also for this dissertation from IOMR. We have used this imicumod 5% in the treatment of dysplasia. Abhi tak we are giving we are giving retinoids, or we are surgically removing it. But trust me, imicumod 5%, it is actually an immunomodulator, but it has got very significant results in dysplastic leukoplakia. Dysplasia is reversed with histological examination, and you can see the lesions disappearing also. So this drug I just wanted to mention here. Next slide, we can just go to the last slide. So, next slide. So lesions are many, and their treatments are also many. Why we have so many lesions in the oral cavity? Because majorly we suffer from two habits which is responsible for these lesions. One is use of tobacco. India is the capital of tobacco usage. And number two is stress which we have in our day-to-day life. So when we can go for tobacco cessation, let us go for cessation of stress also, because if stress will continue, our oral lesions will continue. Thank you so much for your time.
Thank you, sir. Thank you for the wonderful lecture.
Thank you, sir, for such a knowledgeable presentation. We would be starting with the inauguration ceremony soon, so kindly be seated. A gathering of excellence becomes truly memorable when it is graced by individuals whose vision, leadership, and dedication have left an indelible remark on society and the profession. Today, we are deeply honored to be joined by distinguished luminaries whose achievements continue to inspire the dental fraternity and the academic community. With profound respect and immense pleasure, I invite our esteemed dignitaries to kindly grace the dais and bless this prestigious occasion with their presence. Honorable Honorary Brigadier Dr. Anil Kohli, sir, our Vice Chancellor Dr. Sanjay Srivastav, sir, our Pro-Vice Chancellor, Principal Dean Dr. Puneet Batra, sir, Dr. Anmol Bagaria, PFA Section Chair, Dr. Ashish Chandra, sir, PFA Section Co-Chair, and Dr. Dax Abraham, Academic In Charge, School of Dental Sciences, MRIIRS. Please put a big round of applause to welcome our guests. We also welcome all our respected dignitaries of the dais, eminent speakers, respected deans, HODs, faculty members, fellow colleagues, and practitioners from all the parts of India who have come here to grace this wonderful occasion.
Shubham karoti kalyanam arogyam dhan sampada shatru buddhi vinashai deepal jyotir namostate. No academic event begins without invoking the blessings of Ma Saraswati. We request all dignitaries to come forward for the ceremonial lighting of the lamp. Honorable Honorary Brigadier Dr. Anil Kohli, sir. Dr. Sanjay Srivastav, sir, Dr. Puneet Batra, sir, Dr. Anmol Bagaria, Dr. Ashish Chandra, and Dr. Dax Abraham. Can we have a round of applause, please? To begin this beautiful morning with grace, I invite our students Ayushi, Maroon, Anshika, Sachi, and Sakina for Saraswati Vandana.
Thank you, team. I would now request our Pro-Vice Chancellor, MRIIRS, Dr. Puneet Batra, sir, to kindly welcome our own beloved Dr. Sanjay Srivastava, sir, Vice Chancellor, MRIIRS. I would now request Dr. Puneet Batra, sir, and Dr. Sanjay Srivastava, sir, to kindly felicitate our chief guest of the day, Honorable Honorary Dr. Anil Kohli, sir. I request our esteemed dignitaries to kindly welcome and felicitate Dr. Anmol Bagaria and Dr. Ashish Chandra, PFA Section Chair and Co-Chair at Large, Asia Region. I would also request Dr. Ashish Chandra sir and Dr. Anmol Bagaria ma'am to kindly accept our gratitude on behalf of Cynodent International. I request our dignitaries to kindly felicitate our VC Sir MRIIRS Dr. Sanjay Srivastava as the guest of eminence.
We request Dr. Dax Ibrahim to welcome our own Dr. Puneet Batra sir. To kick off this wonderful occasion, I would like to call upon our principal, Dr. Puneet Batra, Pro Vice Chancellor, Dean STS and SHS, Principal STS MRIIRS, who has been a cornerstone of our institution, providing visionary leadership and unwavering support to both students and the faculty. Under his guidance, our college has continued to thrive and evolve, creating an environment where academic excellence and personal growth go hand in hand. He's not only dedicated to fostering a rigorous and dynamic educational experience, but also committed to ensure that each of us feels welcomed and supported here. Sir, we invite you for the welcome address.
Good morning, everyone. Good morning. We have to be awake, today we are in midst of a company which is very rare to get. So, good morning, everyone, distinguished guests, esteemed faculty members, renowned dental professionals, students, participants, everyone. Welcome to Manav Rachana. It's my privilege and honor that, we are here to have this occasion of the conference as well as the award ceremony by the Pierre Fauchet Academy and Cynodent. Pierre Fauchet, we all know, is named after the legendary French dentist Pierre Fauchet, solely recognized as the father of modern dentistry. So, this organization is an internationally respected honorary dental organization dedicated to promoting leadership, ethics, professionalism, and excellence in oral health care. It was founded in 1936, and what I got to learn today that the Indian first branch was found 40 years ago. So, it's a legendary organization which is working for dental professionals across the globe. So, you're not just in one event of an organization which is happening here, it's a subsidiary of a global organization. This opportunity of having this event happened while I was in a conference in Maldives. And Dr. Anmol and Ashish, they have been students, friends, colleagues, everything. And Dr. Anmol mentioned that could we do it in your institution? And I think for any institution, we have to be open. Learning has to be an open-ended process. And today, it's reverse mentoring. You learn from your students. So that is why I just said yes. And, that is what the modern learning teaching has to be. It has to be learning from the students more than teaching them, because what technology, what other things they can impart to us is, mutually beneficial. Well, Manav Rachana is an institution. You can see the logo. It says 30 years. So, it's a legacy which has started many years ago, and it extends beyond classrooms as well as laboratories. We believe that these conferences, these opportunities are not only there for lifelong learning, interdisciplinary interaction, professional networking, they inspire students, faculty members to remain ahead of emerging technologies, evidence-based practices, and also global healthcare trends. Today, I am sorry, I landed at 4 a.m., courtesy Dr. Anil Kohli. He called me up a few days back. He said, I'm boarding a flight, and you will get a call by an ex-doctor. Don't say no. So as soon as that doctor called up, I said yes. I didn't know I was supposed to go to Taiwan for a week. And this week, I had many other commitments planned, but sir is sir. And so I just landed from Taiwan, learning their medical ecosystem, how they work, and a lot of interaction, how we can exchange with each other. So, this is what I believe in helping grow the profession. Manav Rachana is, a part of Manav Rachana International Institute of Research and Studies, a deemed to university. We are NAC A++. We are a Category 1 university. In NIRF, very few North Indian institutions are graded. We were 38 last year, 33 last year. And this year, we also hope that we will possibly do well. But we are an institution which is evolving. Knowledge cannot be static. It's always going to evolve. Therefore, we believe in extending our wings. We did the first ethical committee in a dental college in the country, which got accredited by NABH this year. And when the inspectors came, the assessors rather, they said no dental institution who has tried before was able to achieve. So, I am so lucky my team is there. So you can imagine I was out of the country for a week, and here my team had arranged everything, even the speech was ready for me. So that's the kind of ecosystem you need to build. You need to have leaders, not workers, and these leaders can then lead the process. So, I joined this place 5 years ago. At that time, I would stand and look at every process. Today, I'm sure the processes are well set. This is what leadership is about. In the Manav Rachana institution, in the last 2 years, has done some different things. We've started online programs. Online programs because dentists, when they pass out, they do not get so much hands-on exposure on learning for accreditations, for what are the basic requirements to set up a clinic, what are the basic things to do ethical marketing, what are the basic things to know about income tax, what are the basic things to do daily practices, and how to learn how to set up in an ecosystem of a clinical practice. So we started online programs on AI in dentistry for those people who are passed out and have no access to learning. They can't go to an institute, an engineering school to learn AI, or to a dental institution and learn AI and then incorporate in your practice. We have also started a program on medical legal systems. They are at different levels, basic courses, advanced courses, and super advanced. We've also, started, and that was inaugurated by Dr. Anil Kohli, a leadership program in dentistry with collaboration with 3M, the only leadership program in dentistry in Southeast Asia, again blessed by Kohli sir, and also a fellowship in implantology and endodontics. And as soon as we floated it, it was full. So the first batch is going to be launched within a few days. We are very lucky to have Dr. Anil Kohli here. When you see the name, you don't understand the depth. For me, I say there is only one God, and that God in dentistry is Dr. Anil Kohli. A huge round of applause for him. Padma Shri is something, you Google and you see how many are there. Padma Vibhushan, how many are there. Honorary Brigadier, how many are there. Then BC Roy awardees, how many are there. So when I was traveling to Taiwan, there were few students. So they said, sir, how do you plan your life ahead? I said, you should know who are the leaders, the people who have made the profession proud. Learn to follow their footsteps rather than fall and learn, because life is short. So the first name I said was, please Google the man. Okay, and they were like, sir, is it possible? And we saw his documentary a few days back, and it was a hair raiser. I can tell you that if you get an opportunity in life and you want to grow, please look at that documentary. It teaches you how a person can start from scratch, and failure makes him even excite more. He is a person who is a giver. So, what do you mean by a giver? A giver is basically somebody who, he doesn't just change lives, he inspires lives. So that is what when I think of the name Dr. Anil Kohli, that is what I think, a person who has inspired so many lives. So, inspiration is to create possibilities into beliefs and dreams into action. So I've seen that happen in my dental career, and I'm sure we need to give a standing ovation to the man which I call the God of dentistry, Dr. Anil Kohli. A huge round of applause. It doesn't sink in, actually. Every time it's more and more and more. Thank you, sir, for gracing the occasion today. Whoever gets it from his hand is getting a blessing from the legend himself. Then we have another legend here, Dr. Sanjay Srivastav. A vice chancellor is somebody you see who is least accessible. To reach a vice chancellor is a very big thing in a university. In our university, you need to call the vice chancellor and he will come to your office. He believes in distributed leadership. He has taught many things to me. In the last 5 years, I have evolved, I think, multiple times. And every time I learn from what I was possibly, doing incorrectly and about perspectives of life. He is somebody who is a linker of hearts, who builds bridges without seeing the distances. So, somebody, I can just tell you, when you listen to his speech, one message a day can transform your life. He wrote the practical application of Bhagavad Gita. A colleague of mine was traveling from Mexico. She was here in campus, and while I was telling you about Manav Rachna, we have a number of international faculties who come here, and all because of his blessings, we have international, national exchange. So when these people come, this lady was not well, mentally not well, some problem at home. And he handed over the book to her. I forced him to say that, he signs and gives you a copy, personal copy if you are lucky. And when she landed in Mexico, she said, my problems are solved. I did not know that a practical solution of problems can be held by one person's writing. So again, somebody who deserves a standing ovation. I am just making you exercise. So whatever happens in this university happens because of him. And it happens because he makes us make it happen. Okay? So you can understand that there are some people who build leaders. That is from where it comes. Also, I want to congratulate all of you who are here for the award ceremony, who are here because you have done well in your career. I want to acknowledge a few names because they are a lot more, all of you are dear as professionals and colleagues, and I might miss a few names, but a few names ring a bell with me. Dr. Nikhil Srivastav, I was doing internship, and he was a teacher who came to my college, and an inspiration always. We are so thankful, sir, you made it here. Then, Dr. Ajay Lugani is going to join us soon from AIMS. Again, somebody I started work with. Dr. Sumit Goyal, thank you for the first opening lecture. Dr. Sunali Taneja, we hold a bond from college, and she is one of the teachers who teaches from the heart. Endodontics can be from the heart, and that is what she does. Dr. Amit Bharadwaj, thank you for making it here. Dr. Priyanka Kapoor and Dr. Aman. Again, the young people whose heart beats for the profession and who want to do something exceptional. Also a friend of mine, Dr. Ajit Pillai, who is not only a dentist, not only an orthodontist, but also in trade industry. He is the vice president of Indo-Balkan Trade. He was saying he wanted, he was traveling and he wanted to say hello. So he said, I will come to the college and say hello for 5 minutes. I said, no, you have to be a fellow of PFA. So you have to come and honor the occasion as well. Thank you, Dr. Ajit, for being there. Dr. Jerusala Sukamato, who has come from Singapore, welcome to our campus, and we hope we can make a bridge and do something together. I wish the conference every success and hope that the discussions, deliberations will lead to meaningful advancements in the dental education, research, and clinical perspective. Thank you all for your presence and participation. Jai Hind, Jai Dentistry, and Manav Rachna. Thank you.
Thank you so much, sir, for your inspiring words and always being the constant source of strength and pillar for us.
He is a man of distinct vision and a fountainhead of illuminating ideas, an idol of knowledge, experience, and inspiration to all of us. We admire your spirit of integrity with 100% dedication to the world of education. You are an inspiration to many of us and will continue to do so. We place on record our regard to your physical presence today, sir. I consider it a great honor to welcome Honorable Vice Chancellor Dr. Sanjay Srivastava, sir, the guest of eminence, and request him to give a special address for all of us present here.
Respected Chief Guest of the Day, Brigadier Dr. Anil Kohli, a man with panoramic, pragmatic, and comprehensive vision about life, dentistry, and whatnot. He has given so much to the world of dentistry and to our institution, Manav Rachna. We are extremely beholden with your benign presence, Dr. Kohli Saab, our Pro-Vice Chancellor of the University, and the man who has taken our dental school to the next level, Professor Dr. Puneet Batraji, our Head of the PG programs, Professor Dr. Dax Abraham, the PFA Academy chiefs of the country, the two A's, Anmol ji and Ashish ji, eminent guests sitting in front of us, the awardees, recipients, and the participants of this 19th conference. Whenever I meet Professor Dr. Kohli, I always wonder what to say on occasions like this. You just heard what Professor Puneet Batraji has said about him. And when you come to an occasion like this where we go back, we need to carry some takeaways on convocations and awards. When I look at life of Dr. Kohli, I ask a question to myself: what motivates these persons and what reward them? What is reward to Dr. Kohli? And I go back to the learning of Srimad Bhagavad Gita, where Lord of Shri eloquently elaborated about laws of natural reward. And today on this convocation, I want you to carry home 3 natural rewards, law of rewards, as propounded by Lord of Shri. The first and foremost, when we come to occasions like this, the first law of natural reward is feeling of competence. Whatever profession you are in, if you know the know-how of your job, and this know-how extremely well, and you get a perpetual smile on your face, that gives you a natural reward. And this natural reward is feeling of competence. But after becoming who's who in the world of your respective area, say of dentistry, say as an endodontist, when he is rewarded with what not in the area of dentistry, then we go back to the next level of natural reward. This next level is feeling of self-control. This feeling of self-control is something very different when you are talking only to yourself and you are only reporting to God. Those who know him closely, the kind of routine he follows, and the way he lives a very disciplined life of self-control, that gives you a different kick altogether in life. And lastly, why he is here. And after 1 hour, he is traveling to another destination for a bigger program about which, if he wishes, he can talk. Another program, many dentists are waiting for him in the capital of our Punjab, where he would be again interacting with many, and this takes us to the third and the highest level of natural reward, which talks about feeling of purpose. With what purpose I am here? On purpose, if I don't know where to go, it doesn't matter where we go. So each one of us are born with some purpose. And I am sorry to say, 99% people, they leave this world without knowing the purpose. And that is the highest level of natural reward. To conclude on this convocation, on feeling of purpose, I am reminded by a story of Buddha. Buddha was always accompanied by his cousin, popularly known as Ananda. Ananda was his Bua's son, and he always accompanied him. And those who have read about Buddha, he was first and foremost criticized by a person who is beloved to him very much, his own better half. And our Hindi poet Maithili Sharan Gupta ji has written very well in a poetry called Sakhi Se. And the poetry goes like this. Sorry to Singapore friends, I go back to Hindi. Sakhi ve mujhse keh ke jaate, मुझको बहुत उन्होंने माना फिर भी क्या पूरा पहचाना, छात्र धर्म के नाते सखी वे मुझसे कह के जाते. So Ananda was one person who lived with Buddha through and through, from thick to thin time, and then when he reached to everything in life. And suddenly one day Buddha said to Ananda that, you know, tomorrow onwards I am going to leave this world. I am going for nirvana. So Ananda was crying profusely and he said, I have managed the whole world, but you never talk to me. You have never given me any takeaway for life. Please talk to me. It is very difficult for me to live without you in this life. And the last word of Buddha, on purpose. Buddha said to him, and that is my message to you for this convocation, Apo Deepa Bhava. Be your own light. If you want to attain something, be your own light. And Lord of Shri says in Srimad Bhagavad Gita, chapter 6, verse 5, Atmeva Atmanev Bandhu, Atmeva Ripu Atmana. यह मनुष्य आप ही तो अपना मित्र है और आप ही अपना शत्रु है. I pray to God to give you wisdom to be your own friend in this life and to know your purpose and take your life to the next level. With this, on behalf of each one of us at Manav Rachna, please accept our admiration and love. Lots of best wishes and compliments. Jai Hind.
Thank you, sir, for always motivating us and inspiring us.
It is an honor and privilege to welcome a person of this stature on the dais to share his words of wisdom. I take this opportunity to invite our chief guest, Honorable Honorary Brigadier Dr. Anil Kohli, sir, for sharing his words of wisdom with all of us present here.
Good morning, everyone. First of all, I don't know why I have to speak here, and a lot has been said. You know, in life, as Dr. Srivastav said, the purpose, what purpose you have, and what is your goal in life. As he said, 90% of the people don't know. They come in the word and they go away. There are so many things I can tell you. The institution where you are standing, I have seen when from its inception. What I mean by inception, I was involved in setting up this institution because I was heading that time as a member, as an executive member, as a president of the Dental Council of India. And what growth in education or bringing the good citizen and human being from this institution. You know, profession is one side. You become doctor, you become dentist. But to becoming a good human being is much more important, which has the values, human values. With the changing time, lot has changed. I've seen the face of dentistry from 1972 onwards, which means almost 28 and 26, 54 years. And many phases I have seen. And I have many people, those who I recognize. Nikhil is sitting here, Sonia is sitting here, Gauri is here, Puneet is here. Sanjay Srivastava I know, not as a vice chancellor, as a person. I have seen him in another big university, Amity University, where he was heading. And the character building in an institution and discipline and passing on to the generations and generations, that is the main aim. You know, you go to a function when you are at a position. You go to a function when you are a participant. When you go a function, when you are organizer or you are sponsor or you are getting something. But you rarely go to a function when you are nobody. Today I am nobody. I don't hold any position in anywhere. But the love and affection which you get even today, even after leaving my position in, I think, 2010, even today I have to attend 2 functions. And nobody forces you to come here. It is your wish, your desire, what you want to do in life. I had my own day. I had my game of golf. I am here. In the evening, I will be in Chandigarh. That is a sense of fulfillment. I have reached to a stage where I have to give it back to the society. I'll go one step further to you. See, I became a dentist not by a choice, because in that time, it was the leftover from the medical field, those who used to join the dentistry. But it is your passion, blessing in disguise, right? So I became a dentist. If today if you ask me, a medical man cannot have what I have, whether it is a family, whether it is money, whether it is a name, whether it is a fame. So all these things are not by yourself. It is destined. You have to reach somewhere. You have to do. But you have to work. Nothing is going to happen till you work. Each one of you can be one step ahead of me. When I started the professional career as a fresh pass out, I got selected into the army, got rejected because I had a flat foot. But I became the brigadier later. It's the destiny. I was a good student but failed in the first professional, but never looked back. I used to look on the person with whom I started my career, Dr. M.L. Soni. I used to read a name. He's a Padma Bhushan. He's a honorary colonel. And with the time, everything came in my way. There was a professor in surgery in the medical school of King George's Medical College, and I used to read his triple FRCS, and without knowing the full form of FRCS. So it looks like FRCS, FRCS, FRCS. Dr. Dave. Nikhil must be knowing. So we used to look at it. Then a day came, I had all the 3 FRCS from Royal College of Surgeons, Edinburgh, Glasgow, and London. So it is your destiny which brings you. Today I don't aim, I never aimed, I never knew Anmol, name I heard. And she just called me, sir, I want you to be here. So I said, what should I do? But then I said, this is a young person who is coming up and doing something good for the profession. So why not? Without realizing I have another engagement in the evening in Chandigarh. But I said, okay, doesn't matter. Sanjay was not supposed to be here because he was to go with his wife to the medical consultation today. But destiny changed his appointment and he's there. So that's what happens when your goals are good and your intentions are good. Puneet is here. He could have taken off and he could have rested and then come. He landed at 4 o'clock and 8 o'clock he is there. So all these things is the passion for your work, passion for your family. Now here I see, like, I'll say not 90 but at least 80% are the girls. And there was a time when I was a student, there was 1 girl and 39 boys. How the time changes. In life, change is the only thing permanent. Rest everything is not permanent. People think there is no change. Change is the only thing which can change. Now, what Anmol gets out of it? Now, getting your professional capabilities and your achievement in the society towards the humanity, which is being recognized by the PFA, which is a big thing. And it is not a degree, it is a responsibility being put on you to serve the humanity. So I was coming back to that, the thing, like, I became a dentist in 300 rupees into 4 years, 1200 rupees. That's all. 300 rupees was the annual fee, 4 years was the program, and 20 rupees was the room rent for the hostel in King George's Medical College. And there was no tube light, there was no fan in the room. Today, my daughter, when she goes, I have 2 daughters, both are doctors. When she went to the school, she needed a air-conditioned room, fridge in the room. So how the change has happened. And with the AI now, with the artificial intelligence, other day I was at a symposium, somebody asked me, like, AI is going to replace the medical professional? I said, no. AI is going to replace the doctors who are not getting into the AI. So you have to accept the change and you have to adopt yourself. And the time is not far off, you will see in coming days. AI is going to be the part of the medical education and the quality of treatment and the things happen. So now again I'm coming back about 1200 rupees, you become the doctor. So when the nation and the society is the taxpayers' money, with you studied in a government college. So now your responsibility comes back to the society. What you can go back to the society. So what makes you happy and what makes you the satisfaction? Only yesterday I had a patient and who came and she said, Doc, you may not recognize me. I came to you 27 years back and today I'm coming with my daughter to you. So that is the affection and love which makes you happy and sense of fulfillment. Okay, if I have done something good, that's why after 30 years, the next generation is coming to you. Now let me give you one more example, which will be very interesting for you, and then I had a person who calls from the US, and he says, I need an appointment. Firstly, he checks about whether this man is the right person for me to go or not. So he checks about my credential on the Googles and all. Then he calls my office, on such and such date I'll be in the town and I want to see this doctor. So he walks into the office, then he checks up whether does he have these gadgets in his office or not. So then he tells them, I do not need any treatment. I just want to meet him and ask him. I said, okay. So he walks in, he's an Indian guy, and he said, Doc, I need this treatment. I said, what? Okay, my root canal was done. It's a real story, I'm not telling you. And my MB2 is missing, the doctor didn't do. And here is my CT scan, here is my report, and here are the things I want you, do you have a microscope? And you are using, and I want this MBT to be treated. And do you use the sodium hypochlorite or you use the hexadine? Up to that extent. I'm telling about the AI. I said, okay, I kept listening. I said, okay. I said, give me a minute, I'll take an radiograph. I took an radiograph. I could see there is a perforation in the pulp chamber and whole thing is gone. So I told him, I said, sir, I don't think your tooth will be saved. I don't want to do, but I have a question for you. Why you came all the way? And then he raised one more question. And if you think you cannot do, then you can refer me to somebody who is doing this and who can do for me. I said, okay, I'll do that. I said, why did you travel all the way and why don't you get it treated there? So he said, Doc, I thought it will be very expensive in US. So that's why I wanted to be treated. I said, number one, your tooth cannot be saved. And do you think I will charge you less than that? That was my reply. Because I can dictate. I can dictate. I will not dictate. So he finished everything. He said, what's your concern? I said, nothing, I don't want to charge you. So I wanted to build up. Money doesn't give you everything. So I said nothing. So he was surprised. He spent half an hour and he's still not charging me. So he'll speak to 100 people. He went to so and so and he spent so much of time to X-ray also, but he didn't charge me. So then I called him back. He came back. He said, do you know why did I ask you all these questions? I said, why? He said, I'm an Indian guy, settled in US, and I'm in AI business, and I'm making the AI apps. Can you believe that? So that is the future. You have to be prepared. You know, the Indian system, we never had your registration. Once you become a doctor, you are a doctor. I am the man who changed that. I said, till you do the continuing dental education, your registration will not be renewed. And same applies to the education. If you are not doing one paper publication, I will not make you reader or professor. It was a very hard decision. And third decision was, even if you don't mark your attendance or biometrics, you won't. The whole country went against me. And today it is mandatory for everyone, even in the nursery. You cannot take your attendance if you're not. So self-discipline and self-character is very important. So change is the one thing which comes and goes. And we are all human beings. For me, it's very good to be amongst you today and share my life with you. But it is your own judgment, it is your own decision if you want to be good. The sky is the limit, and I want to see each one of you is standing here where I am standing. Thank you, Jai Hind.
Sir, you have served as a guiding light for all of us and will continue to do so for the young professionals in the making. Thank you very much for your inspiring words.
So what I request you all, that from today onwards on MRDC website, you will have a link. People can read what Dr. Cohen is coding video about which one is he talking about. So all of you can access to that and you can see how and what happened to Dr. Kohli. That videos are request to be on our website.
Sure, sir. Sure. Thank you. May I now request Dr. Ashish Chandra, Co-Organizing Chairperson, Director, Cynodent, Vice President, Indian Society of Dentistry, PFA Section Co-Chair, Section at Large, Asia Region 9, to come up for welcome address and brief about PFA Forshad Academy USA and its legacy.
A very good morning to everyone present here today. It's my profound honor and privilege as Section Co-Chairman, Region 9 of the PFA Forshad Academy and organizing co-chairperson of this landmark global summit to warmly welcome you all to the 19th World Dental Sciences and Oral Health Conference. Along with the esteemed PFA Forshad Academy Convocation and Awards and National Dentist Awards 2026. Let me begin by acknowledging the distinguished dignitaries on our dais whose leadership and vision elevate this gathering. It's my honor to welcome our respected Chief Guest, Honorable Dr. Anil Kohli sir. Sir is a true legend in the field of dentistry. We welcome you, sir. I welcome respected Dr. Sanjay Srivastav sir, our guest of eminence, Honorable Vice Chancellor, Manav Rachna, MRII, RS. We welcome you, sir. I welcome Dr. Puneet Batra sir, Pro Vice Chancellor. Thank you, sir, for your constant support and efforts in making this conference a grand success. Warm welcome to Dr. Dax Ibrahim, sir. We welcome you, sir. I welcome Dr. Anmol Bagaria, Section Chair, Section at Large, Region 9, PFA Forshad Academy. Thank you for being my constant support. Thank you. Also, I welcome all the respected dignitaries of the dais, Dr. Nikhil Srivastav, sir, Dr. Sonali Taneja, ma'am, Dr. Sumit Goyal, sir, Dr. Aman Chaudhary, Dr. Jaslin Sukamto, and all the deans, principals, faculty members, fellows, and delegates who have came from all across the Asia region. Today's conference is a powerful symbol of our profession, unity, resilience, and outstanding capabilities. At Cynodent and the PFA Forshad Academy, we are steadfastly believing in propelling dentistry forward, not only through groundbreaking scientific innovations, but through unwavering community service, peer recognitions, and an enduring commitment to lifelong learning and excellence. This conference builds on 2 days of highly specialized pre-conference certificate courses, which we have yesterday, covering cutting-edge fields like lasers, dental implants, laminates and veneers, intentional reimplantation, and conscious sedation. I hope they were the wonderful workshops that are transforming the landscape of dentistry. Scientific sessions are already underway, showcasing through provoking lectures from leaders, global experts in oral health. Our academic rigors in further extending through engaging online scientific paper and poster presentations. We take immense pride in hosting the Pavitra Academy, Convocation and Awards, and the National Dentist Awards, honoring those whose unwavering dedication, vision, leadership, and passionate service continually uplift our profession and inspire future generation. These accolades embodies the essence of dentistry: compassion, innovation, and relentless perseverance. Our strategic partnership with Maharashtra Dental College amplifies the academic strength of this conference and underscores our commitment to fostering global collaborations and knowledge exchange. Prepare yourself to dive deep into the extraordinary experience of learning, sharing, and forging connections that will ignite new ideas and possibilities. Whether you join as a speaker, learner, or honoree, you are an internal to the pulse of this dynamic community, here to grow, inspire, and lead. On behalf of Team Cynodent International and PFA Academy, I reaffirm our resolute commitment to serve you, strengthen our bond, and champion exemplary standards in dentistry. Together, let's create us a conference that will be remembered for its rich knowledge, enduring friendship, and transformative impact. May your time in this magnificent city, where heritage converse with innovations, be profoundly enriching, inspiring, and empowering. Thank you, everyone.
Thank you so much, sir. We also have a video address by Dr. Ricardo R. Gutmann, Trustee PFA Asia Region. May I request all of you to watch the video and be a part of this inspirational words.
Greetings of peace to all. It is my honor and great privilege to congratulate the entire section at large in India. On behalf of the PFA International President, Dr. Gabby Caspo, our International Executive Director, Robert Catoy, I extend our warmest welcome to all the newly inducted PFA Fellows. Special salutations to your dedicated and hard-working Section Chairman, Dr. Anmol Bagaria, and Co-Chairman, Dr. Ashish Chandra. Your leadership makes this milestone possible. Today marks an important chapter in your professional journey. As fellows of the PFA Academy, you are now called to lead by example, to inspire, to mentor, and to serve your fellow dentists. Keep the fire in your heart. Continue to discover your full potential as dental professionals. Commit yourselves to sharing your time, skill, and knowledge so that others may follow the standard you set. As your trustee for Region 9 Asia, I look forward to visiting you again, to witness your future projects, and to see how you uphold the ideals of PFA Fellowship in your section. May you succeed in building a stronger community, one where there is respect, excellence, and dedication to echo forward to the next generation of fellows who will carry on the true mission and vision of the Pierre Fauchard Academy. Again, my heartfelt congratulations to all, and we welcome you to PFA family.
Thank you. We would now start with the PFA Convocation and Awards hosted by Pierre Fauchard Academy, Section at Large, Asia Region 9, at the prestigious venue of Maharashtra Dental College, Maharashtra International Institute of Research and Studies. We request the fellows to be ready in the convocation gowns. Kindly please carry your motorboard in your hand. It will be worn on stage during the convocation ceremony, and after the convocation, kindly place your tassel to the left side. I now invite Dr. Ashish, sir.
Pavitra Academy is an honorary dental service organization established in 1936 by Dr. Elmer S. Best, a US-based dentist. PFA was founded to help dental professionals to prevent its literature from commercial interest. Elmer, passionate concern for knowledge and raising of professional standards, laid the groundwork of the academy. PFA have 11 global regions, 142 sections worldwide, 55 sections in US, 87 sections in the America, Europe, Asia, Africa and Australia. PFA has more than 6,000 global members. PFA is an affiliate member of FDI and APDF. Père Fauchard Academy is named after the Père Fauchard of France, who is the father of modern dentistry. He wrote a book named Le Chirurgiens Dentiste ou des Dents, the first true textbook of dentistry. The mission as a fellow of the Père Fauchard Academy is to recognize and develop outstanding leadership in our profession internationally. The objectives of the Academy is to fulfill through its meetings of international sections, annual awards, presentation of the Fauchard Gold Medal, the Dental Trade Industry Award and the Elmer Best Memorial Award, the Student Award of Merit and the publications of Dental Abstract and Dental World. The goals of PFA is to make PFA known throughout the dental world, to have the most outstanding fellow dentists in every country of the world, to select and induct individuals of the highest ethical, moral and professional standards, to develop service-oriented projects, to orient all PFA leaders with uniform workable guidelines, to make PFA a peer-recognized body by virtue of its appreciation awards, fellowships and its service to dentistry. This is the PFA organogram. The Père Fauchard Academy, our current president, Dr. Gabi Kaspo, who is the international president, Dr. Pankaj Patel, sir, immediate past president, Dr. Ricardo R. Gutmann, PFA Asia trustee, Mr. Robert Katoy, executive director. We are the section chairmen of section at large. PFA Fellowship. PFA Fellowship is by invitation nomination to honor accomplishments in dentistry and encourage future productivity. Professional leaders select fellows based on contributions to dental literature, service to the profession and service to the general community, thereby bringing credits to dentistry, are among the criteria sought in recruiting new members. The PFA Museum. PFA is a dental history museum, was established in 2000. The museum houses several displays related to dentistry. The museum is located in Nevada, US. This is the PFA Museum. This is the PFA head office. This is from our last visit to the head office. The PFA annual gala and ADA conference we attended the last year in Washington, DC. The section achievements. Under the PFA section at large, various colleges across the region have undertaken a remarkable community service initiatives demonstrating their unwavering commitment to improving public health and overall well-being. During year 2024 to 2026, a total of 1,530 health camps under the banner of PFA were organized, providing essential medical and dental care to underserved population. These camps, conducted across diverse locations, collectively catered to 1,52,770 patients, offering treatment, oral cancer screening, preventive care service, and comprehensive health education. In addition to impactful community outreach, the section has continued to strengthen its academic and profession foundation. Till date, 6 PFA conference has been successfully conducted by our section, reflecting the section's dedication to excellence, education, and collaboration. And we are happy to announce that we have given more than 30% fellows of PFA International, which is from our section. Across these 6 conferences, we proudly hosted 120 plus distinguished speakers, organized 40 plus hands-on training courses, conducted 700 plus scientific presentations, and 60 plus continuing dental education program, all of which have significantly benefited dentists across the globe. A total of 540 fellows has been inducted so far, representing not only young and practicing dentists, but also some of the most distinguished dental professionals across Asia. This esteemed group includes renowned clinicians, deans, principals, heads of departments from both government and private institutions, as well as high-ranking defense dental officers, all of whom stands as true pillars of the dental fraternity, contributing significantly to the advancement and upliftment of dentistry. Furthermore, the section proudly recognizes 250 plus awardees honored for their outstanding contributions, leadership, and service to the profession. This collective effort through community service, academic excellence, professional development, and recognition, showcase the unmatched dedication of Asia Region 9 to advancing dental healthcare, fostering leadership, and uplifting the standards of dentistry across the continent. This is the PFA community services held across the country. These are the exclusive benefits of being the fellow of section at large. The future plans are to maintain our unmatched milestone of inducting 540 fellows in a single year, the highest in the history of PFA, to strengthen and broaden PFA social outreach and community service initiatives, to advance excellence in dentistry by continuing impactful colleges and student awards that inspire and motivate future leaders. The Model Section Award, the Pavitra Academy founded in 1936, has grown to these regions across the global regions. Established in 2014, the Model Section Award honored such exceptional commitments and inspired sections worldwide to pursue excellence aligned with the Academy's highest goal and ideals. The last year, the PFA section at large has been honored with the prestigious Model Section Award among the 140 global sections around the world. The recognition celebrates their outstanding contributions, exemplary leadership, and extraordinary initiatives that have consistently elevated the stature of sections and strengthened their impact on the international platform. Our section has also received the world record for its community services. Now we begin with the induction ceremony. Sir.
I request the fellows. So first we have Dr. Monica Jadhav. She is an maxillofacial prosthodontist. Next we have Dr. Abdul Azam Khan. Dr. Abdul Azam Khan, he is an oral and maxillofacial surgeon, professor at Azamgarh Dental College. Can we have a big round of applause for each fellows? Dr. Anushka. Dr. Anushka Patnaik, she is an oral and maxillofacial surgeon from Malla Reddy Dental College for Women. Dr. Harshala Dr. Harshala Manchalwar, she is a maxillofacial prosthodontist and implantologist. Dr. Vidushi Gupta, Dr. Geetanjali Arora, Dr. Geetanjali Arora, she is an oral and maxillofacial surgeon, assistant professor, Guru Tegh Bahadur Hospital, New Delhi. Dr. Diksha Gupta, Dr. Anand Purushottam, Dr. Beena Kashyap, Dr. Sridhar Reddy, Dr. Ajit Devendra Joshi, Dr. Ajit Devendra Joshi. He is an oral and maxillofacial surgeon, professor and head, Department of Dentistry, PIMS, Udaipur. Dr. Siba Soni, Dr. Ipsita Menon, Dr. Ipsita Menon. She is PhD in Public Health Dentistry, professor and head, Kite Institute of Dental Sciences, Bhubaneswar. Dr. Sobit Zakaria, Dr. Shobit Zakaria, BDS, FGDS and FDS. Dr. Chaitanya Chapidi, Dr. Sudhankar Babu, Dr. Sapna Rani Mahapatra, Dr. Kavyashri M, Dr. Deepak Gurang, Dr. Deepak Guram is MDS in Public Health Dentistry, District Program Officer, CMO Office, Bilaspur, Himachal Pradesh. Dr. Ashish Pathak, Dr. Ashish Pathak, he is an MDS orthodontist and dentofacial orthopedics. He is assistant professor at Azamgarh Dental College. Dr. Shikha Anand, Dr. Ayushi Shahai, Dr. Ayushi Shahai, she is an MDS in conservative dentistry and endodontics. Dr. Tirumagal, Dr. Tirumagal, she is a pediatric and preventive dentist, Assistant Professor, Sri Venkateshwara Dental College, Pondicherry. Dr. Blessy, Dr. Blessy, she is a cosmetic dentist at Civil Hospital. Dr. Shivashakti M, Dr. Shivashakti, she is an MDS, PGDHPE, PhD, FICP, MFDS, Director, Institute of Health Profession Education, Sri Balaji Vidyapith, Pondicherry. Dr. Hina Sheikh, Dr. Hina Sheikh, Dr. Syed Ahmed, Dr. Syed Taqir Ahmed, Dr. Manisha Kumari, Dr. Rohit Nandan, Dr. Anuja Moher, Dr. Anuja Moher, she is a periodontist, Assistant Professor, D.Y. Patil Dental College, Pune. Dr. Manisha Kumari, she is BDS and MDS in Periodontics, Government Dental College, Raipur. Dr. Nitya Ramesh, Dr. Nitya Ramesh, she is an orthodontist and dentofacial orthopedics from Savita Dental College, Chennai. Dr. Deepti Dandu, Dr. Renu, Dr. Nilab, Dr. Nilab Kalita, he is BDS and dentist at Dibrugarh. Dr. Abhya Gupta, Dr. Abhya Gupta, Dr. Jaiseline Sukamanto, Dr. Abhya Gupta, she is PhD in periodontology, professor at King George's Medical University, Lucknow. Dr. Jaiseline Sukmanto, she is DDS, she is a council member and committee chair from Singapore Dental Association. Dr. Neerav H. Parekh, Dr. Ramya Ramaswamy, Dr. Shrishti Jolly, Dr. Yash, Dr. Venkatesh Balaji Ange, Dr. Venkatesh Balaji Ange, he is an oral and maxillofacial surgeon, reader at Maharashtra Institute of Dental Sciences and Research, Latur. Dr. Jay Vinod Rane, Dr. Nilmani Prakash, Lieutenant Colonel Dr. Devendra Sharma Srivastav, Dr. Rakesh D, Dr. Rakesh D is General Dentist at Sai Dental Care, Bangalore. Dr. Nida, Dr. Nida Salim, Dr. Daniel Tang, Dr. Nida, she is an assistant professor at RDC PIMS Loni, an orthodontist and dentofacial orthopedics. Dr. Monica S. Verma, Dr. Daniel Tang, he is BDS dental surgeon, No Frill Dental at Singapore. Dr. Monica S. Verma, she is a prosthodontist, senior lecturer at YMT Dental College and Hospital, Kharghar, Navi Mumbai. Dr. Komal, Dr. Navraj, Dr. Komal R. Rayabagi, she is a prosthodontist at One Dentistry Advanced Dental Implant Center, Mangalore. Dr. Priyanka Sachdeva, Dr. Navraj Palta, she is an orthodontist and dentofacial orthopedics project consultant, Lady Harding Medical College and Associate Hospitals, New Delhi. Dr. Abhinav, Dr. Priyanka Sachdeva, she is a periodontist and preventive dentist, Associate Professor, Santosh Dental College at Santosh University, Ghaziabad. Dr. Abhinav Jaiswal, Dr. Smita Ji, Dr. Abhinav Jaiswal, he is an oral and maxillofacial surgeon. Dr. Ujjaini, Dr. Ujjaini, Dr. Lalita, Dr. Smita Ji, she is a BDS and founder of Sai Dento Care. Dr. Lalita Yadav, she is a professor and head at Kalka Dental College of Department of Oral Pathology and Microbiology. Dr. Bhumika, Dr. Chin Win Tan, he is a doctor of clinical in orthodontics, principal orthodontist at Australia. Dr. Ping Ping, she is a BDS, Honors in Bachelor of Science in Dentistry, Doctor of Clinical Dentistry Orthodontics, Principal Orthodontist at Australia. Dr. Wilfried Kuhn, he is a Director and Principal Dentist at The Point Dental. Dr. Bhumika Sehdev, BDS and MDS in Periodontology and Oral Implantology, Professor DJ Dental College of Dental Sciences, Ghaziabad. Dr. Shubhan Gandhi, Dr. Shubhan Gandhi, he is a tutor at Department of Public Health Dentistry, Maharashtra Dental College. Dr. Suchit Khetrapal and Dr. Tanu Nangia. Dr. Sujit Khetrapal, he is a prosthodontist, founder and chief dental surgeon at Khetrapal Dental Care, New Delhi. Dr. Tanu Nangia, Dr. Lavina, Dr. Lavina, Dr. Tanu Nangia, she is professor and head of Department of Pediatric and Preventive Dentistry, Manav Rachna Dental College. Dr. Lavina, Dr. Mohammad Javed, Dr. Lavina, she is MDS in Periodontology, founder LBS Dentofacial Aesthetic Center, New Delhi. Dr. Navjot Kaur, Dr. Mohammad Javed, he is a periodontist, founder Nexa Dental Surgery and Implant Clinic, New Delhi. Dr. Navjot Kaur, Dr. Gagandeep, Dr. Ajit, Dr. Navjot Kaur, she is BDS and founder of Nexa Dental Surgery and Implant Clinic, Delhi. Dr. Ajit. Dr. Ajit is Vice Chairman and Trade Commissioner, Indo-Baltic Trade Council. Dr. Abhita. Dr. Neelmani Prakash. Dr. Neelmani Prakash is a dental surgeon at the Dental Hub, New Delhi. Dr. Abhita, MDS in Orthodontics and Dentofacial Orthopedics, Reader at Manav Rachna Dental College. Dr. Neelmani Prakash. I request all the fellows to please line up in front of the row so that we can have a group picture for the official website. Dr. Sapna. Dr. Sapna Rani Mahapatra, she is Associate Dentist at Dental Clinic and Implant Center. I request all the fellows to please come forward for the group photograph and stand in a queue in front of the podium. Few fellows can come upstairs. We need 10 fellows upstairs only. I request all the fellows to kindly stand at their positions for the oath ceremony at their designated seats. Dr. Kishore Mahale. Dr. Kishore Mahale in the field of prosthodontics and crown and bridge from GDC Chhatrapati Sambhaji Nagar, Maharashtra. Next we have Dr. Sonali Vishal Mahajan. Dr. Sonali Vishal Mahajan, Department of Prosthodontics from GDC Chhatrapati Sambhaji Nagar, Maharashtra. Dr. Dhanashekaran Balakrishnan, Department of Prosthodontics, JKKN Dental College and Hospital. Dr. Dhanashekar Balakrishnan in the field of prosthodontics, JKKN Dental College and Hospital. Dr. Shipra Gupta, Dr. Shipra Gupta in the field of periodontology and oral implantology from Postgraduate Institute of Medical Education and Research, Chandigarh. Dr. Shiva Shakti, Dr. Shiva Shakti Manivaskan in the field of prosthodontics and crown and bridge from Indira Gandhi Institute of Dental Sciences, Pondicherry. Dr. Sonali Taneja ma'am. Dr. Sonali Taneja in the field of conservative dentistry and endodontics from ITS Dental College, Muradnagar, Ghaziabad. Dr. Chaitali Umesh Hambre. Dr. Chaitali Umesh Hambre in the field of pediatric and preventive dentistry, GTC Chhatrapati Sambhaji Nagar, Maharashtra. Dr. Maya S. Indurkar in the field of periodontology and oral implantology, GDC Chhatrapati Sambhaji Nagar, Maharashtra. Next we have the Lifetime Achievement Award. I request everyone, please stand and respect the awardees in their name. First we have Dr. S. Jayachandran in the field of oral medicine and radiology from Dr. MGR Medical University, Chennai. Dr. P. Mahesh in the field of prosthodontics and crown and bridge from Kamineni Institute of Dental Sciences. Please give them a big round of applause for the Lifetime Achievement Award in the field of prosthodontics from Kamineni Institute of Dental Sciences. Dr. J. Baby John. Dr. J. Baby John in the Department of Pediatric Dentistry from Vinayaka Missions Dental College. Dr. H.P. Suma Soni. Dr. H.P. Suma Soni, Department of Pediatric and Preventive Dentistry, MM Dental College and Research, Maulana Ambala. Dr. M.K. Sunil. Dr. M.K. Sunil. Thank you, everyone. We have the for lifetime contribution in cleft and craniofacial orthodontics, we have Dr. Puneet Batra, sir. Big round of applause for Dr. Puneet Batra, sir, for the lifetime contribution to the field of cleft and craniofacial orthodontics. Thank you, everyone. We are starting with Student of the Year Award in the UG category. For Community Service Award, I would like to call Dr. Anmol sir from Department of Public Health Dentistry, Manav Rachna Dental College, for outstanding community service. Student of the Year UG category, we have Parmi Singh from second year BDS, Khushi Bhandari, second year BDS, Taslima Kalari from fourth year BDS, Parmi Singh, she is from Sharad Pawar Dental College and Hospital. Khushi Bhandari, second year BDS from Sharad Pawar Dental College and Hospital. Taslima Kalari from fourth year BDS. Mansi Mittal from fourth year BDS. Tanvi Tushar for third year BDS. Mithuna T for fourth year BDS. Shreya Banerjee, second year BDS. Vaishnavi Patil, third year BDS. Khushi Thakur, fourth year BDS. Rishabh Vaidya, third year BDS. Lovina Rochwani, third year BDS. Pranita R, first year BDS. Anjali Katyar, second year BDS. Chandini M, third year BDS. Pravasi Neva, fourth year BDS. Janvi Vadva, second year BDS. Tanishka Singh, third year BDS. Dilpreet Kaur, first year BDS. Aisha Rifa, first year BDS. Mansha Shajad, fourth year BDS. Mansa Sajad, 4th year BDS. Riya Nepune, 4th year BDS. Myra Kalra, 4th year BDS. Neha Gangale, 4th year BDS. Avantika Raheja, 4th year BDS. Pranjali Damane, 4th year BDS. Awardees from Manav Rachna Dental College. We have Pari Mittal from 1st year BDS. Mehak Pant, 3rd year BDS. Anshika Batra for 2nd year BDS. Jasmine Kaur Sidhu for 3rd year BDS. Samriddhi Arora for 4th year BDS. Aisha Zareen, 4th year BDS. Afifa Shahid, 1st year BDS. Juvansh Sachdev, 3rd year BDS. Ayushi Thadani, 2nd year BDS. Abdul Rahim, 1st year BDS. Dr. Misbah Kadri for overall BDS and Dr. Shubham Bharti, 4th year BDS. Moving on to Student of the Year, PG category. We have Dr. Palak Hirani from Department of Conservative Dentistry and Endodontics. Dr. Vegi Mohan, Department of Conservative Dentistry and Endodontics. Dr. Rashmi Suresh Dadmal, Department of Periodontology. Dr. Simran Kriplani, Department of Conservative Dentistry and Endodontics. Dr. Ruchita Tejrao Patil, Department of Periodontology. Dr. Divyansh Sinha, Department of Prosthodontics. Dr. Vidhina Patil, Department of Pediatric Dentistry. Dr. Uma Maheshwari S., Department of Pediatric Dentistry. Dr. Komal Sanjay Surve, Department of Pediatric Dentistry. Dr. Shanmuha Priya S., Department of Oral Pathology and Microbiology. Dr. J. Shri Shah, Department of Oral and Maxillofacial Surgery. Dr. Nishchita A., Conservative Dentistry and Endodontics. Dr. Amreen Firdoz, Conservative Dentistry and Endodontics. Dr. Shyama Pramod, Department of Orthodontics and Dentofacial Orthopedics. Dr. Diksha, Department of Prosthodontics. Dr. Kashmiri Chaudhary, Department of Conservative Dentistry and Endodontics. Dr. Abhinav Jaiswal, Oral and Maxillofacial Surgery. Dr. Shivani Khandelwal, Conservative Dentistry and Endodontics. Dr. Shreya Bansal, Department of Periodontology and Implantology. Dr. Simran Chadda from Department of Prosthodontics. Dr. Tony Lego from Department of Orthodontics. Dr. Soumya Verma, Department of Conservative Dentistry and Endodontics. Dr. Rashika Singhania, Department of Pediatric Dentistry. Moving on to Young Researcher UG Category Award. Neha Agarwal, Soumya Vats, Maulik Katoria, Kanak Wagmere, Rishita Dulet for Young Researcher UG Category. For the Young Researcher UG category, Maithili Gawali, Mansi Tomar, Tanvi Tushar, Lalit Pawar, and Aisha Zareen. Next we have Young Researcher for PG category. Dr. Palak Hirani from Sharad Pawar. Dr. Pooja Chitlange, Dr. Akshata, Dr. Bhushan Kalmela, Dr. Anushri J. Dr. Palak Hirani, Dr. Pooja Chitlange, Dr. Akshata, Dr. Bhushan, Dr. Anushri, Dr. Vishakha Kumar, Dr. Lubhasna, Dr. Palak Jain, Dr. Siddhi Rane, Dr. Vinita Shah, Dr. Soumya Parashar. Moving on to the PFA competitions, we had 3 competitions, that was reel making competition, dental art and dental photography. For reel making competition, for dental art we have Ashwin. Dental art, Ashwin Shyam, Sharon X, Cheryl Rachel, Anna Dharani, Nicole Lasaro, Khushi Latoria, Pranjal Adinke, Chaitali Bootle, मानसी ताक, मोहिता घोष, चेतना बाली, नयन ए दोने, ईशा अग्रवाल, अनुषा गुप्ता, गौरी मसने, श्रेया सिंह, एम मालिनी, मुत्तु कौशी, दिलप्रीत कौर, डॉक्टर चैताली उमेश अंबरे, कोमल चित्राका, कृपा वाडीचार, डॉक्टर तेनमोजी BR, कशिश संजय विशानी, खनन वाधवानी, रुद्रांश धूमल, समीक्षा रुपेश फंदी, अनन्या सी, वसुनीता S, अब्या फातिमा सोहेल, पूर्वा प्रमोद, देवी प्रिया S, आयुष गोंगले, रेनू दरकार, रोशनी कोड़े, आयुषी निकारे, For reel making competition, we have Khushi Bhandari, Neha Gangale, Mansi Singh, if anyone have the award from their college students, they can collect it afterwards. For reel making competition, Khushi Bhandari, Neha Gangale, Mansi Singh, Riddhi Chopade, Kanak Wagmare, Rudransh Dumal, Trishla Mahindra, Parnavi Sudhir, Pooja Hirarami, Shraddha Ishwarkar, सेजल ओक्टे, चैताली बुटले, श्रेया सिंह, रेनू दरकार, मोहिता घोष, समीक्षा रुपेश, ऋचा यादव, राशि अग्रवाल, आस्था, गुरु प्रसाद, moving on to the last competition award, that is dental photography. Sagar M, Dr. Akash Shailesh Thakre, Syali Varankar, Bushra Bushra, मोहिनी कदम, के जगदीश, अवंतिका रहेजा,
I would now request the dignitaries on stage to kindly felicitate the speakers. The first speaker for the day, Dr. Sumit Goyal. Dr. Nikhil Srivastava, sir. All of you, please give a round of applause for the speakers. Dr. Sonali Taneja, ma'am. Dr. Ajay Logani, sir. Dr. Jesseline Sukamto. Dr. Amit Bhardwaj, Dr. Aman Chaudhary, Dr. Priyanka Kapoor. Thank you to all our dignitaries. We would now invite Dr. Anmol Bagaria ma'am, PFA Section Chair, Section at Large, Asia Region 9, to deliver the vote of thanks.
A very good afternoon and warm greetings to one and all present here. I once again welcome you all to the 19th World Dental Sciences and Oral Health Conference. Theme of the conference is Bringing the Future of Dentistry Now and Beyond, and Periforchar Academy Section at Large Convocation and Awards 2026. Firstly, all thanks to God for blessing all of us with His choicest blessings. I would extend my heartfelt gratitude to all the dignitaries on the dais who have graced the occasion and inaugurated our conference today. Respected Dr. Anil Kohli sir, Honorable Chief Guest, Dr. Sanjay sir, Vice Chancellor Madhav Rachna Educational Institutions. He was our guest of eminence. Dr. Puneet Batra sir, thank you for your constant support and guidance in making this program a grand success. Dr. Ashish Chandra, Dr. Dax Sabran sir, thank you for your constant support again in making this event a grand success. Thank you all for gracing the occasion with your presence and your constant support. I would also like to thank all our dignitaries of the dais, respected guests, deans, faculty members. I wish to extend my sincere thanks to the entire organizing committee. Thank you for your constant support and efforts. We could not have come this far without you. I also thank all the speakers, clinicians and academicians who have taken out time from their busy schedule and made it here to enhance the knowledge and skills of our delegates. A big thank you to all my dear delegates and students who have trusted us and joined us today. Sorry if I have missed any name. I am highly thankful to each one of you. I would end by saying a famous saying by Dr. APJ Abdul Kalam: all birds find shelter during a rain, but eagle avoid rain by flying above the clouds. So problems are common, but attitude makes the difference. Thank you once again for being there with us, giving us your valuable time, trust, support, and all the efforts. Wishing you a very happy day and a happy conference ahead. Thank you.
Thank you, everyone. We will resume with the keynote speakers. I would like to call upon our next keynote speaker, Dr. Nikhil Srivastava sir, to enlighten us on the topic Revitalizing the Dead, Biological Management of Non-Vital Immature Permanent Teeth. To moderate this session, I would call upon Jesslyn Sukamoto ma'am, Council Member and Committee Chair, Singapore Dental Association since 2024, Founder and Director, Real Conventions, and Professor and Mentor at the University of Melbourne. We welcome you, ma'am. Sir, please.
A distinguished academician, clinician, researcher, and educator whose contributions to pediatric dentistry have had a significant impact both in India and internationally. Dr. Srivastava is currently the Dean, Professor, and Head of Subharti Dental College and Hospital at Swami Vivekanand Subharti University in India. He is also serving his 4th consecutive term on the Science Committee of the International Association of Pediatric Dentistry, a testament to the global recognition of his expertise and leadership in the field. Throughout his career, Dr. Srivastava has combined clinical excellence with a strong commitment to education and research. He has authored more than 105 publications, accumulated over 2,200 citations, supervised more than 80 research projects, and mentored numerous postgraduate and doctoral students. His work extends beyond academia into innovation, with multiple patents and novel clinical concepts that have been adopted in practice. His contributions have been recognized through prestigious fellowships from institutions including the Royal College of Physicians and Surgeons of Glasgow, the Royal College of Surgeons of Edinburgh, the International College of Dentists, and the National Academy of Medical Sciences. He has also received numerous awards for his contributions to dental education, research, and clinical practice. Today, Dr. Srivastava will be speaking on a topic that remains one of the most challenging and fascinating areas in pediatric and regenerative dentistry: revitalizing the dead, biological management of non-vital immature permanent teeth. As clinicians, we have all encountered immature permanent teeth with pulpal necrosis, cases where traditional treatment approaches often leave us with significant biological and structural limitations. Advances in regenerative endodontics are now changing the way we think about these teeth, opening possibilities for continued root development and improved long-term outcomes. Please join me in giving a very warm welcome to Dr. Nikhil Srivastava.
Thank you very much, Dr. Jasleen. If I'm right, I have
Yes.
spelled rightly?
Yes, yes.
Yeah, Dr. Jasleen, thank you so much for kind introduction. First and foremost, heartiest congratulations to all of you, those who got the awards in various categories, those who got the fellowships. Many congratulations. It is not just the award, it is a big responsibility which is now on your shoulder. You have to prove worthy of these awards, right? Well, I know after having a long inauguration, almost 2.5 hours, and you people have been sitting since 9 o'clock in the morning, not allowed to have a drink also. You must be very hungry, thirsty also. I will try to be as possible. Logani has already instructed me 2.5x. Right? So I'll just try to be as fast as possible. How many of you are interns? Just can you raise your hand? Interns? All right, very few. Final years? Postgraduates? Postgraduates? All right. And who are these people? Second year, third year? All right, okay. So probably this topic will be more suitable for second years, third years, interns, and postgraduates. I'm a pediatric dentist, so when I got a call from Dr. Puneet saying that you have to deliver a lecture, so I was little out. What kind of topic should I? Because being very pediatric dentist kind of topic will disinterest you, because the audience is very mixed kind of, you know, you are interns, postgraduates, and you know, faculty from different specialties. So I chose a topic which is of interest to everyone, right? Now, too many endodontists are sitting here. My wife also happens to be endodontist, so I know. In practice, I have more than 60 to 65% cases pertaining to endodontics. Okay, everyone wants to do root canal therapy, vital therapies, and all, right? So I topic which is between the conservative dentist or endodontist and pediatric dentist, that is pertaining to the management of young permanent tooth which because of any reason has become non-vital, right? This is my topic. Can you change? Can I have this slide changer? No. No, it's not that. Okay, so yes, please click now. Next, yeah. So this is, no, please go back. Back. Previous, yes. So I will start my presentation with this beautiful by Charles Darwin. He says that it is not the strongest of the species that survives, nor the most intelligent that survives. It is the one that is most adaptable to change. Now, in place of species, you can add like dental surgeons, right? Even if you are the most intelligent, it's not necessary that you are going to survive in your field. You will survive only when you are adaptable to change. And what is the change? Because the dentistry is a branch of medicine which is changing with a very fast pace. Few years back, there were few technologies, materials which were very frequently used. Nowadays, they are not in use. If I example, when I was pursuing my post-graduation from 1993 to 1996, I was there as a postgraduate student in KGMC. Calcium hydroxide used to be the poison, considered as a poison in pediatric dentistry. And now see the difference. Today we cannot think of any procedure which can be done without calcium hydroxide in pediatric dentistry. It becomes so prevalent. You need to adapt to the change. And this is why I have chosen this topic. Next, please. Everyone thinks that once the pulp is either dead or irreversibly inflamed, we just think of non-vital. Remove the pulp and then, operate it. But there are now newer technologies, newer techniques, newer thought processes come into play now. We can change and we can revitalize the tooth, right? So next, please. Now, those pediatric dentistry or general dentistry would come across these kind of cases. Child 12 years, and then he comes with a non-vital tooth. And when you take a radiograph, next please, click please, next, this kind of picture appears, right? And suddenly we think, what to do now? The tooth is non, there is hardly any dentine, there is hardly any root, what to do now? Next please. Similar case, a fracture, trauma comes to you, and if you take a radiograph, next please, this kind of picture. A large root canal, very thin dentine, shorter root. What now? Right? Next please. But before we go into detail, we have to ask these questions. So I will take you to the first, those who are in first year, second year, would remember all these things. Next please. What is young permanent tooth? Right? So a tooth where the root has been formed, we call it as immature permanent tooth. Now you have to remember two things. That when the tooth erupts into the cavity, only 2/3 roots are formed. 1/3 will take 2 to 3 years. Similarly, when the tooth erupts, even the enamel is not yet completed. It takes another 2 to 3 years to complete. So this duration of 2 to 3 years post-eruption, you can call the tooth as young permanent, immature permanent tooth. Next. For every development, you need a vital pulp. Correct? Next, please. The next question is, why tooth root development ceases? Okay? So you all must be remembering about the Hartwig's epithelial sheath. Do you remember or not? Two-layer structure. What is the role? The role is to form the root. Then why it is not functioning? Why roots are not forming? Because it derives nourishment from the pulp. And because the pulp is now dead, there is no nourishment for Hartwig's epithelial root sheath, and tooth becomes non-vital, and the roots stop functioning. Next, please. Next question. Well, what happens when the root development stops? So, you will have a very short root, you will have a very thin dentine, and you will have altered crown to root ratio. Ultimately, the tooth becomes so weak that it cannot sustain the masticatory force, right? Next, please. So the main causes for the necrosis of the pulp in young permanent tooth, for anterior, the most common cause remains the trauma. For posterior, caries, and there are few developmental defects which also result in early pulp exposure and necrosis of the pulp. Next, please. Now, the biggest problem is these patients are in growing phase. What kind of rehabilitation you can do when these cases report to you? One, the easiest option is to extract, but after extraction, how will you rehabilitate? So one is giving the RPD, removable partial denture. But these young children, they do not accept it. Okay, this is our experience. Second option can be fixed partial denture. You cannot give fixed partial denture because the adjacent teeth are all young permanent. Tooth preparation is altogether very difficult because most of the time these teeth become very sensitive. Sometimes they get exposed also. And moreover, the children are in growing, these patients are in growing phase. So FPD is also not an option. Third one is implant. Obviously, in growing phase, we cannot give implants. Why? If we give implants, what will happen? The growth development of the that area will be restricted and that implant will get submerged if you start giving implants in the growing phase. So all these options are not feasible. Next, please. So what is the best option? Next, please. So the best option is try and retain such teeth which are young permanent, shorter root, thin dentine. Try to retain these teeth into the oral cavity. Next, please. So no, please go back. Go back. Yeah. So this is in broad the non-vital pulp therapy options for the young permanent teeth which are presently available. One, you can say non-biological, maybe chemical option, where we try to produce or create an apical stop so that you can perform root canal therapy. Because if the root apex is open, you cannot obturate the canal by root canal therapy. One option can be you just create an apical stop so that you can perform the root canal therapy. The other option, which is a more biological type of thing, you allow the body to heal and work for itself so that the complete process of apical formation can take place. Next, please. So first, all final year students, interns would be knowing about this apexification procedure. As I said, you have to just create an apical stop, young permanent tooth, which is non-vital, so that you can perform root canal therapy. Next, please. These are some of the materials which are very frequent. And as I said, calcium hydroxide is the second most common material available in the dental clinic after zinc oxide and all, right? So calcium hydroxide. Then you have some other materials which are not very frequently used, but still, they are in use, mineral trioxide, bidentine, ceramics, etc. Next, please. So the traditional apexification, which involves calcium hydroxide, click karte rahiyega. So calcium hydroxide can be used in powder form or it can be used in paste form. But this apexification is a multi-appointment procedure. So every 6 months you have to recall the patient, take the radiograph, or whether the apical formation is taking place, and you have to see whether the complete canal is filled with calcium hydroxide or not, and if not, then you have to replenish it. Okay, this is a big thing, what you have to do it. Sometimes we add form in it so that the apical formation or apical plug formation is fastened. Next, please. This is one of the cases done with calcium hydroxide. And see the third radiograph here, where the canal has been obturated after the apical plug was formed. And you can appreciate there was no lengthening of the root, no thickening of the dentine, and you can see the apical plug which was formed, which is little. radiographic apex. Next, please. So as I said that every 6 months you have to call the patient, you have to replenish the calcium hydroxide if it is dissolved, and the process takes place up to 2 years. Now these children are the students, the patients are the students. Many times they don't have time to come for the recall checkup. And if they are studying in boarding, altogether it is very, very difficult. So then there is a process which is known as apical barrier technique, and say single step apexification, where you are not waiting for calcium hydroxide like material to apical barrier to form, rather you create apical barrier immediately, right? So we call it as MTA apexification, and I'm sure you all must have read about the MTA. You have gray MTA, you have white MTA, right? The normal setting time is around 2.5 hours to 3 hours, and you have the fast setting MTA as well. But I will not recommend to go for fast setting, which sets something like GIC, until you are well to deal with MTA, right? Next, please. So the technique is very simple. So you have gained a straight line axis. What is a straight line axis? You gain the axis so that you are the apical portion or apex of the tooth, right? Clean the canal. Do not go for conventional cleaning and shaping. Minimal preparation is to be done, and it should be medicated with the calcium hydroxide. You can use powder, you can use paste, whatever you want, and seal it for 2 to 3 weeks. Next, please. After 2 to 3 weeks, just flush out all the calcium hydroxide which you have filled into the canal, dry it, and then pack the apical third of the root with MTA, and then you obturate, and next one you can, next please. One of the cases, the picture is not very clear here. You can see with the MTA apexification what we have done. We have just disinfected the canal with calcium hydroxide. Apical third has been filled with MTA, and then the canal was obturated. This is how we do single or two-step apexification. Next, please. Now, whatever I have told till now, next, in both, either you go for calcium hydroxide apexification or MTA apexification, the canal is non-vital because you have completely extirpated the pulp. The roots are not going to be increased in length or thickness, so shorter roots prone for fracture. Dentin thickness is also not going to be increased, so you have a thin wall and apical barrier. When you use calcium hydroxide, it is not a calcified barrier. For first year, second years, and years, kindly note, with calcium hydroxide, when we create an apical barrier, it is of cheesy consistency and it has multiple pores in it, communication with the periapical area. So even if slightest pressure, you will able to, you will remove the complete barrier which is formed over a period of time. Altered crown and ratio, and then ultimately you need a full coverage, that is a cap onto such teeth. So after waiting for so long time, or you have used MTA, the tooth still remains very, very weak. Next, please. So the question arises, do you have any other option where we can strengthen the tooth by increasing the root length, by increasing dentinal thickness? So the option is this, and answer is yes. Next, please. And this is what our topic is. So the procedure which I am going to tell you is a biologically based procedure designed to replace the damaged structure, including the dentin and dentin pulp complex, right? And this is, next please. And in other words, we call it as a rotary endodontics, all right? Basically, rotary endodontics is an interplay of three things. The stem cells, we all know, these are the clonogenic cells which are present in our body, particularly in the tooth. Second, the growth factors, which something, they fasten the process of multiplication of these stem cells, and scaffold is a base on which we grow and multiply the stem cells. So there is an interplay of these three things, and we call it as rotary endodontics. Next, how can we achieve this? So there are two major approaches. Next, please. One which is known as tissue engineering technology. Now this is nothing but growing the dental pulp in the lab. So you need to take out the stem cells from the individual, and then you have to grow stem cells in the presence of growth factors and scaffold. And once your pulp is ready, you have to implant the whole pulp into the disinfected root canal. Correct? But that requires a high-end lab. The second one is a simple method where you have the lab which is present in the human body or in the body of the patient itself. We call it as cell homing. What we do, we try to, these stem cells, we try to just take these stem cells in the presence of scaffolds and in the presence of growth factors into the disinfected canal instead of transplanting it from the labs to that particular tooth. Next, please. So the cell homing or revascularization basically has one thing. The idea is if you can establish the bleeding into the disinfected root canal, the stem cells, they will come with the blood. Blood will become a scaffold. It will trap stem cells in it, and of growth factors within the blood and from the dentine, and all put together, they will just try to revascularize the dead tooth. Next, please. So, thank you so much. So now coming to the protocol, you have to understand not every case is fit for revascularization or the regenerative endodontics. So first and foremost, you have to select a good case. So the case selection involves, number one, the tooth with the necrotic pulp and immature apex. Why I say this? That even if you find the tooth is completely mature, necrosed, you should not try revascularization or cell homing. It's not going to be successful. Second, the tooth should have sufficient crown so that it does not require post and core, because you cannot afford to re-enter the canal once the revascularization has done. Third, the patient should not be allergic to any of the antibiotics. And then the compliant patient. First and foremost, the patient should have patience. When you inform that I'm going to try something biological, you have to wait. If something fails, then we have to go back to the conventional procedures. You have to take these consents from the patient. Number one, that it may require 2 or 3 appointments, and then you have to come every 6 months for the follow-up. Number two, I am going to use a group of antibiotics. You should not resist to that. Number three, there might be some adverse effects with the antibiotic. Patient should give consent for this. And number four, if because of any reason, if the procedure fails, then we will go back to the conventional procedures like MTA apexification or calcium hydroxide apexification. Then coming to the procedure. Now I want all of you to kindly just pay a little attention how to do it. It's not a rocket science. The only thing, it has to be very, very precise. So first sitting, what you have to do, you have to just ensure that the oral cavity is almost devoid of bacteria. You cannot divide it, but you can reduce the microbial load. So there is a term which is known as pre-procedural mouth rinses. You can use with the help of calcium hydroxide, chlorhexidine, and ask the patient to switch the oral cavity for 1 to 2 minutes, and then you just isolate the tooth, right? Then gain the straight line access. And for small file, now there is no need to prepare the canal, okay? You have to just create a space with the help of maybe 40 number file, so that whatever medicament you are going to insert into the canal should have enough space to go inside. And then the minimal instrumentation, as I said, don't try to remove anything from that. You just have to create this space. Another important thing, now you have to disinfect the canal. So how to do disinfection is a very, very tedious job. So the recommendation is that you have to use 20 ml of 1.5% sodium hypochlorite, and the canal is irrigated for 5 minutes. So what does it mean? It means that you have a syringe of 5 ml, right? The 5 ml syringe should be very slowly irrigated 4 times, okay? So one syringe should, you have to devote at least 1.5 minutes for irrigation. What you have to use, another thing is endodontic needle. What is endodontic needle? Which is the closed end and side vented, so that your sodium hypochlorite does not go into the periapical area. So you have to irrigate with 20 ml for 5 minutes, followed by another 20 minutes, 5 minutes of irrigation with 17% EDTA. What is the function of EDTA? It is a chelating agent. It opens up the dentinal tubules so that you have sufficient growth factors which can be released through the, right? So that you have to keep in mind. And then dry the canal. And then the next one is the disinfection. So you have used 1.5% sodium hypochlorite, and then you have to use triple antibiotic paste or triple antibiotic solution. So there are several evidences which suggest that if you use ciprofloxacin, metronidazole and minocycline in 1:1 weight by volume ratio, you will be able to achieve a good disinfection within the canal. So this is how you have to take 3 tablets, 1 tablet each. So in India we have metronidazole 100 milligram or 400 milligram. Then you have ciprofloxacin 500 milligram, and minocycline comes with 100 milligram, right? So weight by weight means that you have to use 100 milligram each, right? And then you have to crush separately and then mix and make a 1 milligram powder with the help of microbalance. Then you have to make a solution of 1 milligram per ml. How to measure 1 ml? 1 ml of glycol or normal saline and 1 milligram of the mixture of these 3 antibiotics is to be taken together, and then your mixture will be prepared. And then you have to slowly inject this solution into the canal in the space which you have created, right? Slowly, so excess will come out, and then whatever solution is going inside, you will have to allow. Again, you must use only and only the endodontic needle, because this solution, if it goes into periapical area, it will certainly harm the stem cells and you will not be able to achieve the revascularization what you want. And then the patient should be sent back for, so normally we recommend the patient should be sent back for 1 month. After 1 month, when the patient comes for the second sitting, what you have to do, you have to just ensure the patient is all right. Then second, you have to just flush out all the medicament which you had given in the last sitting, and then some block anesthesia, not the infiltration. If you are using infiltration, please ensure that there should not be any vasoconstrictor. Otherwise, block anesthesia is the best one. So after you have given block anesthesia, just again flush out everything using the 20 ml of 17% EDTA, followed by normal saline, so that all the antibiotic which you had given in the previous visit should be removed properly. Dry the canal. Then next one, just a minute. Yeah, you can see in the, yeah, in the video, right? So, oh, sorry. Yeah. So after you have flushed out all the antibiotics, then what you have to do, a sterile file you have to take, and supposing you had measured the length like 15 mm, so take file of 18 or 19 mm and try to injure or lacerate the periapical area, okay? And injure the periapical area in such a way that the blood starts coming and filling into the root canal. In the second sitting, what you have to see, just ensure that everything, whatever you had given, yeah. Okay, so this was, what is happening? The second thing, okay. Sitting, okay. So, canal, so it starts root canal, and once it is done and it has reached till the cervical area of the root, then try to stop the bleeding with the help of a very wet cotton, and once it is done, you apply a cola pad, your collagen pack, any collagen pack. And if you have collagen pack, that's very good. If you don't have, there is a small, not recommended, but you can always use the resorbable sutures, okay? You just make a small ball of the wet sutures, pack it into the cervical third of the root, so that it provides a platform for you to insert the MTA. It should be closed with MTA, and then thereafter you can etch, and after that you just seal the excess with the help of composite, or you can use the light cure or dual cure or resin modified glass ionomer cement. So this is how you have to just complete it, okay? Now what happens thereafter? The closure will occur. You have to measure the root thickening, root length is taking place or not, and if you can take the CBCT, that will be very nice, because you will find they have the root closure is happening in three direction, cervicoincisal, mesodistal, as well as buccolingual direction. There are three major factors which influence whether your vascularization is going to be successful. So first is the degree of canal infection. Until you have absolute disinfection, you cannot achieve a good revascularization, number one. Number two, apical diameter. As I said, it is only and only recommended for the young permanent tooth. Many a times in India, it happens, the age is 25 years and he comes to you and says that some 15 years back I sustained this injury, but then I took medicine, there was no problem, now again I have developed pain. But do not try, because the patient's age is beyond 16 years. So the evidences have already suggested that the patient age is beyond 16 years. These revascularization protocols are not going to be very, very successful. And third one, yes, as I said, this is a very good study, by Eurofem, and he said he just compared the calcium hydroxide with MTA and revascularization. And you can just appreciate in calcium hydroxide, neither the root nor the dentin thickness increased. However, in MTA, you find little amount of root length increased. But in the revascularization, you will find a lot of root dentin thickness is increasing and root length is also increasing. How to judge or how to measure this success? There are three criteria. Primary goal, patient should be asymptomatic. There should not be any problem. Secondary goal, there should be increase in the thickness as well as the length of the root canals. And third one is a positive response to pulp testing, which is not possible at present. Maybe Dr. Logani will throw some on this, how to measure the status of the vascularity in teeth, because everything is happening within the root. And how to see whether the root has sufficient blood or not, I don't know. Maybe Dr. Logani or Dr. Sonali will tell something, because if you have the electric pulp test, it will not work, because the number is MTA filled. Go for cold or heat test, it will not work. So the only option remains is the laser Doppler flowmetry, and it is not widely available anywhere in India. So the take-home message are these three. Vascularization is a promising biological endodontic procedure for the treatment of immature necrotic tooth. Please do not think of extracting such teeth. Number two, it promotes the root development in all the three directions. So far, far better compared to the conventional apexification. And certainly, the success is directly dependent upon how much disinfection you can achieve. So in conclusion, you have to think little different. Please do not try treating the teeth non-biologically, but think of treating the tooth biologically. And it will give you some amount of success, and it will give you a lot of satisfaction, because you cannot replace whatever nature has given to you. So with this, thank you very much, Dr. Puneet, Dr. Anmol, Dr. Ashish, for giving me the opportunity. Thank you very much, all the audience. Thank you.
Thank you so much, sir, for an enlightening lecture. Thank you.
Thank you.
May I now request Dr. Dax Ibrahim to kindly felicitate our chairperson of the session, Dr. Sukamtu. Now I call upon our next speaker of the day, Dr. Sonali Taneja, to enhance our knowledge on the topic, predictable and painless single-visit endodontics, small tweaks, big results. The session will be moderated by Dr. Pooja Kabra, Professor and Head Department of Endodontics, Sharda Dental College.
Hello, good afternoon everyone. As we proceed with the next scientific session, it's my privilege and honor to invite our next keynote speaker, Dr. Sonali Taneja. She is an endodontist, Dean, PG Studies and Clinics, and Professor and Head of Department of Conservative Dentistry and Endodontics in ITS CDSR Muradnagar. She completed her graduation and master's in conservative dentistry and endodontics from DAV Yamunanagar and was adjudged as best graduate student for attaining highest marks in BDS aggregate in MD University and was also adjudged best postgraduate for her batch. Dr. Sonali Taneja is a passionate teacher and has been postgraduate guide for last 20 years. She has published 89 articles in peer-reviewed national and international scientific journals, most of which are PubMed and Scopus indexed. She has co-authored 6 books. She has guided a couple of ICM-funded research projects. She is a reviewer of many national and international journals and was past associate editor of JCD and is chief editor of Scopus Index Journal of Dental Specialties, and has many awards and medals to her credit. She has been past president of IACD and EC member of IES, and was conferred with Diplomate Indian Board of Endodontics. She was awarded Outstanding Achievement Award by IACD for contribution to the field of conservative dentistry and endodontics. We welcome you, ma'am.
Thank you, Dr. Pooja, for a very nice introduction. And greetings from ITS Dental College, my karma bhumi for the last 25 years. Imagine a scenario, a patient coming to you with severe pain, diagnosed as irreversible pulpitis, coming to a dentist who has suggested a multi-sitting root canal procedure. And another patient with the similar situation coming to you and you have prescribed a single sitting root canal procedure. We can see the journey or the destination is the same for both of them, but the journey for the top one, the top image you can see, that is filled with a lot of hurdles in terms of appointments, rescheduling, time constraints, and so many things. Whereas the bottom picture, the journey is smooth as well as fast. So why single sitting is being preferred by the latest generation, in particular, the survey done by Vela et al. Found that 78% of the patients the treatment against person who preferred a 2 endodontics. And the reason given by one visit, one treatment, and less chair side time. chair side time for a single sitting is definitely longer, but as compared to the cumulative chair side time of multiple appointments, it is less. Then there are lesser injections. Then in case of apprehensive patients, the fear, the apprehension, the anxiety levels, they are much less when the procedure is completed in. And this results in improved comfort and convenience for the patient. So if the patients are asking for it, where is the dilemma? The dilemma is of the operator. And this dilemma is because of certain myths present. The myths are the false beliefs related to single sitting root canal procedures. And that myth is mainly because they are not sure, they are skeptical whether the single sitting procedure will be as efficacious as the multiple sitting or not. And the myth number 1 is that the single sitting procedure, they lead to lower success rates and more operative complications. But it's evidence and fact is that no regime is better than others. Both are comparable, and in both the regimes, both single sitting as multiple sittings, the complications can occur. Then is the myth number 2, that is the post-operative, it is greater in case of single sitting, particularly when done in necrotic. But the evidence and the fact is, as seen from systematic reviews and multiple studies, that there is no such difference whether it is a vital tooth or a non-vital tooth. The third myth is the root canals cannot be disinfected unless and until a medicament is given. But this myth is again busted because the medicaments like calcium hydroxide or triantibiotic paste, they do not ensure complete sterility. And the complete sterility is not even our goal. Our goal is to bring down the microbial levels to a point threshold, and then to entomb them with a good 3D obturation so that they do not thrive. That is our goal. And that is very well achieved by good instrumentation and disinfection with irrigants. So the criteria for single visit endodontic be done in any case, provided the patient is cooperative, the operator as well as the patient, both of them have got time, and it also depends upon the clinical skills and expertise of the operator. The exceptions are only those cases where the mouth opening is not adequate, TMJ problems are there, or there is purulence or acute infections or some complexities in canal procedures. So this is the treatment, ideal treatment protocol to be followed for a single visit endodontics. So this journey starts even before you pick up any instrument, that it starts with pre-medication. And this pre-medication is in the form of either your NSAIDs or steroids or gabapentin. These pre-medication, it is given 1 to 2 hours prior to the start of procedure. And the purpose of giving this pre-medication is you achieve a greater preemptive analgesia, as well as it improves the success rate of your inferior alveolar nerve blocks. So this is the dosage which is prescribed for the pre-medication. Then comes how to increase the intraoperative comfort level. This is achieved only by giving a profound anesthesia. And in single sitting procedures, because they are slightly longer, we need to take long-acting anesthetics like bupivacaine. Lidocaine is to be replaced by articaine. The studies have shown that 4% articaine is better than lidocaine. And in case of hot tooth, we might even go for supplemental injections like your buccal infiltration, your intrapulpal, intraosseous, or intraligamentary. Then coming to pre-endodontic restoration, the goal of this pre-endodontic restoration is to give a good coronal seal which will prevent the contamination from saliva or from gingival crevicular fluid. And secondly, it builds up the wall so that, which facilitates the placement of our rubber dam, and also it preserves remaining tooth structure and prevents the vertical fracture, thereby increasing the predictability and prognosis of our treatment. So the type of pre-endodontic buildups, depending upon the loss of structure, if the loss is subgingival, we can go for deep margin relocation or deep margin elevation. And if it is a circumferential loss, then we can go for donut approach or canal projection approach. Isolation, after you have built up the walls, isolation is very critical and unquestionable aspect of single visit root canal treatment. The mantra, basic mantra should be no rubber dam, no root canal treatment. And a classic study by Abbott, they found that incidence of post-operative pain, it was 78% found to be in cases where rubber dam placement was not done. And it's not just the post-operative pain, we are even talking about higher clinical success when rubber dam are placed. This magnification, this is an important tool for every endodontist, be it be loupes or the microscopes. Loupes from magnification ranging from 3x to 8x, and for doing BMP, you can go for microscopes from 8x to 16x. And the studies have proven that magnification not just improves your precision, it also aids in detecting more of MB2 canals. And this study found out that with no magnification, the detection rate was 26%, which increased to 62% when loupes were used, and further increased to 77% when microscope was used. This is an important aspect before you even start doing your access opening, that is your occlusal reduction. And there are two classic systematic reviews with different inclusion criteria. In one, in which their inclusion criteria took the tooth which was symptomatic with tenderness to percussion, the occlusal reduction considerably reduced the post-operative pain, especially after. And the second review by our own Nagendra Babu, it was done on asymptomatic patients, and it was found that there was no basic significant reduction in pain, whether it was done or not done. Coming to our access cavity preparation, the goals for any access cavity preparation is removal of all caries, then preservation of sound tooth structure, then is complete de-roofing of the chamber. And after de-roofing, the complete removal of pulp, locating all the canal orifices, and last but not the least, which is very important, is gaining straight line access. Here I would like to emphasize, it is not just the straight line access to the orifice, but straight line access to your working length. That is very important so as to prevent iatrogenic errors. And this access of cavity preparation, it has evolved over a period of time from traditional access to conservative and then to ultra-conservative. The rationale behind ultra-conservative, that is your ninja access or truss access, which have come up, the rationale was that they would improve the fracture resistance of the tooth. But the evidence, it says that ultra-conservative axis, there was no difference in the fracture resistance as compared to your conservative axis, and they were associated with a lot of problems. The gaining of straight line axis, all the goals of axis opening, they were really defeated with ultra-conservative axis. That is, straight line axis couldn't be of, there were remnant of pulpal debris, lot of iatrogenic errors, then more chances of missed canals. So how to locate the ones which are hidden? It's not by luck you get the canals. Locating canals or searching for them, it is a basic systematic search. And for that, there are certain tools. First of all, you should be well versed with the knowledge of anatomy of the tooth. Secondly, you should know how to read or interpret the radiographs, and the radiographs have to be taken at 2 to 3 angulation so as not to miss those finer details or missing of any external root canal or any deviations of root canal anatomy. And for this, magnification plays a key role. CBCT, of course, but that is the last resort. And then you do your access modification with your ultrasonics. So there are some clinical tools also, which will help us not to miss the canal. That is your famous red line or white line test. Red line in cases of vital tooth, because the blood percolates from the orifice and it goes towards the groove connecting the two orifices. And that gives us the clue where the next orifice is going to be. Same in case of non-vital tooth. The white debris, they collect along the grooves and they give the clue. If this is not done, then we do the champagne bubble test. In enclosed pulp chamber, what we do is we flood the chamber with warm sodium hypochlorite and see for the bubbling. The bubbling, wherever the effervescence is more, if you try to trough that particular area, you will get that hidden canal. And then we have the dyes like your methylene blue. And methylene blue, wherever the concentration of the dye is more, you remove the dentine and you get the orifice. And there are certain instruments for exploration and negotiation like your DG16s, micro openers. When we are talking about missed canals, we should be talking about MB2s. And MB2, basically, the guide to MB2 is follow the groove, and the MB2 will be present slightly palatal to mesobuccal and slightly mesial to the groove connecting the mesobuccal to the palatal. So, and when trough that area with ultrasonics under good illumination and magnification, once you have removed the dentine, look for the catch. Sometimes what happens is the explorer goes just 2 mm. So in that case, you will need to widen that orifice because sometimes the opening itself is tortuous so as to gain the straight line axis. And then you have to evaluate. And there are long shank burrs available. Those are your Ellen burr, Munz discovery burr, Endo-Z burr, and tips like Startex, ET10, and ET20D. This is the study done by Dr. Ajay Logani sir and the team, and they found, they calculated the distance between MB2 and palatal in Indian population, which also gives a certain clue of finding the hidden MB2s. Then about the mid-mesial canal. Whenever you feel that the mesiobuccal and the mesiolingual canal, they are widely spaced, please do guided troughing of the groove which is connecting those. And that troughing has to be done very judiciously. It should be at the expense of marginal ridge and not towards the furcation area, so that you do not cut the danger zone. So this prevents the chances of perforation while finding your mid-mesial canals. After you have located the canals, now what you have to do is, you have to gain the apical patency. And that patency has to be done with smaller size instruments, 6, 8, 10, 15, with slow watch winding motion, and the instrument has to be pre-curved. In fact, this patency instrument, it gives you the road map of the canal or whatever you are going to find in the apical third. So this has to be done very carefully, and once your patency file is loose, you go for your coronal pre-flaring. And this, the advantages of coronal pre-flaring is it removes maximum amount of coronal debris. So the piston effect, what you observe with your step back technique, that piston effect is not there. So there are less chances of extrusion, so less chances of your post-operative pain. Secondly, when your coronal third is enlarged initially, so there is more room for the irrigants and for better disinfection. Thirdly, it helps to negotiate the apical curvature better without any iatrogenic errors. After you pre-flared, you go for working length determination. There are certain tips to determine the working length with the apex locators so that you do not get inaccurate. First, third generation apex locators are good. Then it is about your apex locator, irrespective of the brand. It needs to be calibrated and it should be adequately charged. Thirdly, you have the pre-endo buildup and pre-flaring, which I've already talked about. You need to have a good, stable reference point. The canals have to be adequately wet and the chamber has to be dry. The canals have to be wet, not with hypochlorite high concentration, because that is extremely conductive and it will give inaccurate readings. So it should be, preferably it should be wet with your normal saline. And then the file which you are using should not be loose, it should be snugly fitting file, and you should not allow it to contact with the metallic restoration. And the cheek clip, tell the patient to pull that cheek clip in the opposite quadrant and not let it contact with the tooth of that opposite quadrant. And then when you are taking the reading, advance the file slowly till you get 0 or the apex. And then you subtract your 0.5 from that particular reading. And then lastly, after taking those readings, cross-check it with the radiograph. This is cleaning and shaping. This cleaning and shaping, initially the glide path, it is made with hand instrument, then with rotary instruments. Then for the single sitting, some of the dentists, they do prefer going for reciprocating single file systems. But the studies have shown that there is no difference between single file systems and multiple file systems, but the post-obturation pain, the post-operative pain, it is more with your single file system and reciprocating system because they are aggressive. They cut a lot of dentine, and those dentine get pushed beyond the apical foramen, which results in pain. So these are the evidence which shows this. Now comes the point that instrumentation alone, is it responsible for the success? No, it's a strict no, because none of the instrument, even the hand or any of the rotary file system, can absolutely touch 100% of the canal circumferentially. And the studies have shown that the area left unprepared for round canals is up to 50%, and for flattened canal it is up to 80%. And we have got a lot of apical ramifications too. So what to do in such cases? For single sitting, so we rely on heavy or thorough disinfection protocol. And for that, we need to have hypochlorite, EDTA, and normal saline for single sitting. And hypochlorite because, why hypochlorite? Because it is excellent bactericidal and it has organic solvent property. So it removes the organic part of the smear layer also. And how to increase the tips, the efficacy of this hypochlorite is, the concentration to be used is between 2.5 to 6%, and the volume to be used should be really high. You should, because we need continuous replenishment, and then we can increase the temperature to 60 degrees to improve its efficacy. And this can be done by intracanal or extracanal heating. Intracanal heating is better, and it is done with ultrasonics, and this definitely, it results in better outcome. And also, if fluid dynamics of this hypochlorite can be improved either with agitation or activation, the efficacy goes further. So these are the devices commonly used are your conventional syringe irrigation systems. And the syringe, the gauge recommended is 30. For an open-ended, we have to place it 2 mm short of the working length, and for side-vented, it should be placed 1 mm short of the working length. But there are problems associated with this syringe irrigation. That is the formation of vapor lock. What happens in the apical third? Because of the interaction of hypochlorite with the soft tissue debris, there is formation of bubbles which get entrapped in the apical third, and they prevent ingress of the irrigant further. So this prevention, so the apical third doesn't get cleaned. So how to break this apical vapor lock is by either agitating or by activating. Now the question comes, what is the difference between agitation and activation? In agitation, you are just increasing the fluid flow, whereas in activation, you are improving the fluid dynamics as well as you are improving the reactivity of your irrigant. So to improve the efficacy, what we have to do is either agitate or we have to activate. And agitation is done with your manual dynamic agitation. In that case, what we do is we take a well-fitting master cone. What we do is we cut it by 2 mm, and then 100 strokes per minute, with the short amplitude strokes, we have flooded the canal and take that cut, well-fitted gutta percha cone, and in and out, 100 strokes per minute, that breaks the vapor lock and it brings the irrigant till your apical third. Or what we can do is we can activate it with sonic or ultrasonics, lasers. In lasers, we have our laser activated irrigation, the PIPs, the photon acoustic, photon induced photoacoustic streaming, and then we have sweeps, which is shock wave enhanced emission photoacoustic streaming. And the literature has proven that laser activation is found to be the best. When a network of meta-regression of clinical trials was done, it was found that the post-operative pain incidence, it was least when it was laser activated irrigation followed by multisonic, followed by negative pressure, then ultrasonic, then sonic, then positive pressure, and last was manual dynamic agitation. So manual dynamic agitation resulted in extrusion of the irrigant, resulting in your post-operative pain. So this is a concept which has recently come up in last 10 years, that your continuous chelation concept, in which we are using mild chelating agents like etidronic acid in combination with hypochlorite. And this continuous chelation, it is done in between the irrigants, between the instrument change as well as the last irrigant. So this continuous chelation, it prevents the debris. At the same time, it has positive effects on dentine. That is, it doesn't erode the dentinal walls. So for the ideal treatment regimen which has to be followed as the final irrigation protocol, it needs 2 ml of 2.5% hypochlorite activated ultrasonic, and we need to do. After that, we have to give an intervening rinse of either water or saline, and then it is again followed by ml of 17% EDTA, again activated for 30 seconds with ultrasonics. Again 2 cycles are given, followed by water, and final rinse again of 2 cycles of 2.5% sodium hypochlorite. So this is the final irrigation protocol which one needs to follow in a single visit root canal treatment. And this protocol has to be strictly followed, and it results in better outcome and better results. So coming to our obturation, the sealers, what all sealers one should prefer. We should prefer epoxy resin, calcium-based sealers. These are preferred, and the studies have shown, the evidence has shown that ceramic-based sealers, they are marginally, not significantly, marginally better than resin-based sealer for early post-operative pain reduction. But overall, both bioceramic as well as resin-based, they have been found to be comparable. Coming to the obturation techniques, we normally have cold lateral, warm vertical, and thermoplasticized techniques. The warm vertical and thermoplasticized techniques, they result in more pain as compared to our cold lateral, and the efficacy is almost similar. So this was the classic systematic review which showed that the obturation material extrusion, it resulted in more post-operative pain. So therefore, the thermoplasticized gutta-percha techniques, where the apical stop is not present and there is risk of extrusion, the pain risk is much more than when we do lateral compaction. Coming to the post-endodontic restoration. First of all, before giving a post-endodontic restoration, we need to clean the cavity, and for that we need to use the cavity cleaners like scrubbing it with ethanol saturated cotton pallet or with micro brushes, followed by air polishing Profiflex or Cavo brushes. And this, after this, then we can give our post-endo restoration. After the cleaning protocol, this gives a better bond strength, better seal of our post-endo restoration. So rehabilitation, that is whether giving a full crown or overlay, onlay, that should be postponed till 1 week, and it should be. Then certain adjunctive therapies, which I would like to talk about. Those are certain non-pharmacological measures which definitely help in reducing the post-operative pain. Here I would like to mention more about the intracanal cryotherapy and low-level laser therapy. So in both the intracanal cryotherapy and low-level laser therapy, what happens is there is significant reduction of the pain. This pain is because cryotherapy, it restricts the tissue metabolism and blood flow, producing vasoconstriction. And this results in less post-operative pain and even on 5th and 7th day of the endodontic treatment. Same is with our low-level laser therapy. It also results in less firing of nociceptors, decrease in histamine release, increase in lymph drainage, all of them contributing to less post-operative pain. There were just 2 slides left. इसका लगता है वो बैटरी खत्म हो गया. Next. So the take-home message is that single sitting root canal treatment, it is for the experienced clinicians, and the 3 pillars for this single sitting is, first is absolute isolation, then is advanced magnification, and third, which is very important, is the rigorous disinfection protocol. This is a strict protocol which is to be followed before you start doing your op. So in the end, I would like to say that the day we stop seeing just the aesthetics, that is how well, okay, moti si canals हमने भर दी और मोटा गट्टा पर्चा, that is radiopaque seen in our X-rays. And we concentrate more on what we have taken out. That is how well we have disinfected the canals. Our success rate of our single sitting procedures, it will go high. This is how we should be doing our root canals in future. Thank you.
Thank you, ma'am, for the wonderful session.
Of Endodontics, Jamia Millia Islamia, New Delhi. Sir is also honorary visiting professor to STS Tehran University, Iran. Dr. Sanjay can welcome the speaker of the session.
The next speaker is Dr. Ajay Logani, boss of Endodontics and president of Indian Endodontic Society. Sir, please.
You've been sitting there, but you've heard the 2 lectures, and I would require your attention for 20 minutes now because we've all come here specifically to talk to you. So probably that would not be a good idea to keep seeing on the phone when we are speaking. So maybe second years, first years, third years, postgraduates, whoever is there, listen to us because we would give you some additional information than what you're already having being taught in your dental program, so I would request your attention for the next 20 minutes. As far as this place is concerned, I've been coming very, very often, and I'm very happy to be at this Congress. Frankly, me coming here is out of affection from 2011, so it's almost 15 years I've been coming to this institute, and in various capacities, sometimes as a mentor, sometimes as an examiner, sometimes as a speaker, sometimes for the board of studies. So I had my previous colleagues also here and my present colleagues. So that's what brings me here often. Otherwise, I do not have much reasons to be here. I think there has been change there. I thank you, the entire team. As Dr. Miglani said, I'm from AIMS and at the Dental Center, and I'm working at the Department of Conservative Dentistry, and I'm heading a very, very dedicated team of postgraduates and faculties and senior residents. I do also take this opportunity to welcome you there if you're at any time site there. As far as this presentation is concerned, I want your attention for a simple reason. I'm going to rush through the next 80-90 slides in 20 minutes. I only have few specific messages. I do realize you probably have not started endodontic therapy, or you've just started, or you're just learning it in the theory. So I'm not going to take you into much details, but just give you some idea what you would be experiencing when you enter the clinics. So just take these messages in your mind, and when you do come to the patients, have this thought process in mind when you would be dealing with your patients. Most of my presentations are evidence as well as my own experience, 30 years of experience, but I do understand that I speak to young people, so everything what I speak is evidence-based, but yes, my experience would also be seen in this particular presentation. You know this guy, Adolf Hitler. He was that person from the German Nazi. Not that I support him, neither do I support his radical thinking, but I wanted to know something about this particular gentleman. He was the most feared person in the world. You do understand, he started the 1939 Poland War, which has brought that, at that time, the biggest human war which is till date considered the World War I and II. He was feared by everybody, but you would be very, very kind of surprised to know that he feared root canal treatment. So the person who feared, was feared by the entire world, actually feared root canal treatment. If you go down to the history, you will see that for one premolar tooth, he underwent 8 sessions, and he never got the root canal completed. And the reason why he did not get the root canal completed was because of the pain. You would also be interested to know that among the top 3 fears, the fear of snakes, the fear of heights, and the fear of getting hurt, the 4th most common fear is actually endodontic therapy. And again, it's because of the pain which is perceived by a lot of patients. Again, if you see, this is something which you would read on the internet, and out of my own experience, that it has been equated to labor pain. So ladies do realize what labor pain is, and a lot of times endodontic pain has been equated to labor pain, and it's one of the most feared words. It's almost like a gold standard to describe pain, that it is worse than root canal. So that's the amount of kind of pain which patients do perceive when they talk about endodontic therapy, to the extent that the American Association from 2016 has had to hold a specific week between the March and April, telling patients that please, with the advent of new treatment options, root canal is not that painful, but still 67% of the Americans feel that root canal is painful. And my experience of 30 years exactly tells that root canal treatment is perceived by patients as painful. And I'm sure the senior practitioners would agree that the first question when a patient sits in your chair asks whether it's going to be painful. they're very, very anxious and they're very fearful that this procedure is going to cause pain. Obviously, the answer to this question is that can we help? And that is what my topic is, management of endodontic pain. The first thing which I need you young dentists to understand is that when a patient comes to your dental chair, he is quite very scared about the procedure, the very sound of the drills, and the fact that he has to be given a local anesthesia, the prick, the injection, and the fear of having pain while doing a root canal therapy is there in his mind. So I would want you to be very communicative with your patients. I always see nowadays that the communication skills is going down with this particular generation. You're more interested in probably the mobiles and the technology, but the communication skills, the skill of being able to talk to your patient is what I would want you to develop during this program of 5 years during your BDS program. Is going to be very, very helpful for you, because you would see that communication is very important. Reassuring the patient that you're going to be taking care of his pain, you're going to be taking care of his tooth, and you're going to be relieving him of his pain. Trying to communicate that itself is going to be very, very important. So the first thing which I would want you to learn is to kind of reassure, how to reassure a patient is what I would want you to do. As far as pain management is concerned, we have the classical 3Ds. Just remember these 3Ds. The first D is definite diagnosis, because as far as endodontic pain is concerned, there are two major painful conditions as far as pulp diagnosis is concerned. So it is very, very important that you establish the right diagnosis, because the right treatment will only be rendered if you have the right diagnosis. Consider this particular hypothetical situation where the patient comes to you, he's been having pain for last 24 hours, is not being relieved by any analgesics. It is being increased whenever he takes a cup of tea or coffee, and he hasn't slept in the night. And when the patient comes to you and all the tests which you do, the EPT or the cold test comes positive, there is no palpation pain, there is no percussion pain, and as far as the radiograph is concerned, it only would show you probably deep or extremely deep caries approaching the pulp. And if you get to understand that the history as far as your clinical features and radiographic features, you would arrive at this diagnosis of symptomatic irreversible pulpitis. This is a true emergency. As far as this pulpal diagnosis is concerned, you have to understand that this is a true emergency. At this stage, I would also want you to take this message that you would need to, in your practice, be able to differentiate between emergency and urgency. How you do it is by simply asking 3 questions to the patient: that how long has this pain been bothering you? Does the problem disturb your sleep? And have you taken an analgesic in the last 3 to 4 hours? If the answer to these 3 questions, please, if the answer to these 3 questions, that if the pain has been extensively intense in the last 24 hours, and I haven't slept the entire night, and I took the painkiller 4 hours back, but the pain is coming back, please be rest assured that this is an emergency. You cannot send the patient back by just giving him analgesics or antibiotics. You will have to intervene, because this is a true emergency, symptomatic irreversible pulpitis. And obviously urgency, you can schedule a patient, but once you have a diagnosis of symptomatic irreversible pulpitis, please understand it's a true emergency and you cannot send the patient back. As I already said, there are few emergencies. Symptomatic irreversible pulpitis and acute apical abscess are the 2 pulp diagnostic emergencies. Trauma obviously is again an emergency. I just wanted to tell you what are the emergencies which you will face. but as far as trauma is concerned, I'm not going to be discussing. Once you've established the diagnosis, the second day is definite treatment. As far as definite treatment is concerned, local anesthesia is what you're going to be achieving because it's a very painful condition. You will not be able to intervene without local anesthesia in teeth with symptomatic irreversible pulpitis. You have to understand that local anesthesia in these teeth are challenging. We call them as hot teeth. And the reason because of why I understand is that local anesthesia do not work very well are two reasons for it. One is the emotional component. You do understand that the patient hasn't slept the entire night. He's popped in 2 or 3 painkillers. He's already groggy. And so the local anesthesia tends to work lesser in anxious patients. The second reason is obviously pathophysiological. I'm not going to go deep into it, but you understand that local anesthesia does not work very well in areas of inflammation. And symptomatic irreversible pulpitis is entirely an inflammatory process of the pulp. So you're really not looking at the anesthesia being very, very profound in such cases. This is where, again, I talk about verbal anesthesia. Again, I bring you to the communication skills. Please talk to your patients. Once you've reassured them, once they are less anxious, the emotional component is being taken care of so that your anesthetic efficacy can come up. So please explain him the procedure and give him the local anesthesia. After explanation, you will experience that the patient is much more comfortable. Once you've done that, obviously pre-anesthetic medications are very, very useful, and we do have literature to suggest that which pre-medications are best. They've told us that dexamethasone, just 0.5 milligram, 1 hour before the procedure. So if the patient is in your chamber, just give him a 0.5 milligram of dexamethasone, or if he's on phone, tell him that take a medication and then come. You would see that the local anesthesia in such cases is more profound. As far as the technique itself, as I said, one of the fears is about the injection needle. So please make sure that you are there with the patient to make him as comfortable as possible. Make sure that you give a local anesthetic jelly so that the mucosa is somewhere numbed before you have the needle being inserted. I do not recommend sprays because that can cause choking. And I always do prefer to do this kind of echo-pressure where you put pressure in the retromolar area with your thumb and gradually massage it and then put your needle there. Please notice that the patient will have less pain as far as needle insertion is concerned. And I always promote the 2-step injection technique where you just take the needle inside the mucosa and do not hit the bone as we are traditionally taught in the INB. Take the needle into the mucosa, drop few drops of local anesthesia there, count 20 in your mind, and then hit the bone. You will understand the patient perceives less pain as far as the INB block is concerned. And this concept of achieving pulpal anesthesia should always stay in your mind as long you practice endodontic therapy. You would need to understand that after an INB, that is an inferior alveolar nerve block, soft tissue anesthesia, that is the lip, the tongue numbness comes in 3 to 5 minutes. But as far as pulpal anesthesia is concerned, it takes 15 minutes. So please keep this in mind, that if you start your root canal therapy within 3 to 5 minutes, thinking I've achieved pulpal anesthesia is wrong. So please keep that understanding in mind also. Supplemental injections, madam also did show intraosseous or intrapulpar or intraligamentary. They're all very, very painful injection techniques. I usually would not want you to recommend these to yourself, and please do not try. An intrapulpal is almost like an electric shock. So if you follow those concepts of having profound anesthesia by pre-medication and by waiting for 15 minutes after an INB so that you achieve pulpal anesthesia, I am sure that most of your patients would be comfortable and you would not require these supplemental injection techniques. But if you do, please master them first before you go on for the supplementary techniques. And I always feel that the patient should be comfortably numb. I think Dr. Miglani would know this song, but I don't think so the newer generation would know this song. It was by Pink Floyd, Comfortably Numb, and I do not want you to be called as a liar, because a lot of times the dentists tell, this is the picture in our Bible book, Ingle, so you want to be avoiding that, and that is where the importance of profound anesthesia is there. As far as treatment is concerned, the type depends on time. I'll talk about the emergency treatment of symptomatic irreversible pulpitis. Frankly, these patients come unannounced. They are an emergency, as I told you. They're not appointed between your scheduled patients. So if you do not have much time, and you have to relieve, you see, you will have to remember this. I told you it's an emergency. You cannot send the patient back without analgesic, with analgesics and antibiotic, and say, come back another day. You have to intervene. But if you do not have time, sufficient time in that particular day, but you still have to intervene, I would want you to do this in such teeth. In teeth with symptomatic irreversible pulpitis, if you do not have time, just give local anesthesia and remove the coronal pulp tissue. That is, do just a complete pulpotomy. You will notice that the patient has relieved of his pain. And I do not want you to put any dressings after having done pulpotomy, because we have sufficient literature that none of these medications, as far as after doing a pulpotomy as an emergency procedure, would work. In turn, they tend to increase the inflammation. So please, after pulpotomy, just a cotton sterile pellet and a temporary is sufficient. You really do not need to depend on pharmacresol or eugenol. As I said, they tend to increase the inflammation. And please, this is not more available, but I understand the Indian products are available. These are those pulp mummifying agents. I do not want you to use them in teeth with irreversible pulpitis. Your patient would curse you because the pain would increase in such cases if you apply that. If you have moderate time, that means you have 25-30 minutes between your two scheduled patients and you are trying to get this emergency done, maybe a partial pulpectomy. What do you mean by partial pulpectomy? Is to remove the pulp tissue of the largest canal. So if in the mandibular molars, it happens to be the distal canal, and in the maxillary molars, it happens to be the palatal canal. So if you have 25-30 minutes and a little more time, the only thing which you need to do is remove the pulp tissue from the most major canal, that is the distal for the mandibular molar and palatal for the maxillary molar. You would be able to give relief to your patients. Obviously, if you have the patient has got postponed and you have this emergency coming in, you can do single visit root canals, as Madam did explain to you. That would be the best in these cases, but that depends on how much time you have. As far as literature is concerned, they have told us that as 3 methods of emergency management, that is complete pulpotomy or partial pulpectomy or single visit root canal. As far as if the time is less, the best results are given by full pulpotomy, that is just the removal of the coronal pulp. You would give sufficient time, sufficient relief to your patient, and it's a simple technique and it relieves the symptoms very effectively, and that is what. But make sure, because you haven't completed the root canal, you call this patient back within 24 to 48 hours, because if you do not do so, the inflammation will set in again and the patient will start experiencing pain. So if you've done full pulpotomy as an emergency measure for teeth with symptomatic irreversible pulpitis, make sure that your patient comes back in 24 to 48 hours. Occlusal reduction in such cases is required because we really do not want any trauma from occlusion in such cases, because that would again increase the inflammation. What we are looking at is reducing only the functional cusp, and only in teeth where there is already apical periodontitis present is the only teeth which get benefited from occlusal reduction. But it is a good thing in such teeth to do occlusal reduction. The next D is the drug therapy. you need to know only two things as far as drug therapy is concerned, that the most effective drug is a combination of brufen and acetaminophen, and it comes in this particular combination in our country with Combiflam, which is 325 milligrams of acetaminophen and 400 milligrams of brufen. So in our country, it comes as a combination, ibuprofen or Combiflam. That's the best. The only other message as far as analgesics is concerned, don't ask the patient to take it SOS. You need to give a regime depending on the severity of the pain. Either you're going to tell the patient to take it every 8 hourly, or moderate pain, then ask the patient to take it every 12 hours. So please, painkillers in symptomatic irreversible pulpitis not to be given as SOS regime. They got to be given as around the clock. Second thing is, the most common or the most effective combination happens to be acetaminophen and brufen, ibuprofen combination. As far as antibiotics is concerned, no role of antibiotics as far as efficacy in reducing pain. So please do not use any antibiotics in such cases. There is no evidence that it improves the efficacy of local anesthesia. Please, no antibiotics. If you see, we are the capital of antibiotic resistance in the world. This is 2015 data, 12 years old, and please, and it is showing that the maximum misuse of antibiotics is through dentists. I do not want you to take this habit at this young age. So make sure you do know when to prescribe antibiotics, and which ones to prescribe antibiotics is also which I would want you to learn. As far as the second emergency I told you is the acute apical abscess is what we would want to do, and I would want you to know what exactly you need to do. Again, you cannot send the patient with analgesics and antibiotics. You need to intervene because there is pus accumulation there. You need to do an access opening so there is relief of pressure. The pus is a pathway for drainage of the pus is established. The first irrigant in these cases is not sodium hypochlorite because it can clump the pus cells, stopping the drainage. So please do not use the first irrigant as sodium hypochlorite in these cases. Use warm saline in cases where you have acute apical abscess. And once the drainage has stopped, you have to complete the biomechanical preparation, and you have to give a calcium hydroxide and never leave the pulp chamber open. 90% are teaching this and practicing this. I do not want you to take this message. Please never ever leave the pulp chamber open, even in teeth with acute apical abscess. Make sure that the drainage is stopped. Most of the times, 15 to 20 minutes, it stops, and then you please close the tooth. Please know, extraoral fermentation, only warm water holds are recommended in teeth with acute apical abscess. These are cases which you would require to give antibiotics, but again, only in those cases where the patient has fever, lymphadenopathy, or it is spreading into a cellulitis. So again, in acute apical abscess, you would probably need to give antibiotics, but be making sure that these three things are present when you are giving the antibiotics. And as far as antibiotics is concerned, amoxicillin is a broad spectrum, 500 milligram, 3 times a day. Please add Metrogel, 400 milligrams, 2 times a day is what is the basic course as far as antibiotics is concerned. And you would have to recall the patient within the next 4 to 5 days to complete the endodontic therapy, because again, if you delay it, there is no much use, and the leakage would take place from the temporary restoration, getting the canals infected again. And make sure that incision and drainage is kept as the last option. It's not a routine option. I see a lot of times in peripheral care hospitals doing this kind of treatment for acute apical abscess. We really do not want to do it. You've got to be very, very case specific in such cases. And obviously, as general dentist, I would want you to learn this habit of referral. If you think you are unable to manage the case, it's better to refer to a specialist who can probably manage it better. I end this presentation with what my understanding as far as endodontic pain is concerned. First thing, The patient never lies you. Take my word, pulpitis is painful, extremely painful. We have known cases where patients have committed suicide, shot themselves because of the pulp pain. You need to understand why pulpitis is painful. When you have an abscess in your skin, the skin can expand and the pain gets dissipated. But as far as the tooth is concerned, it is a low compliance thing. That means the pulp, that is pulp inflammation, has no space to expand because it is covered by dentine, then the enamel and the cementum down, so the pulp inflammation cannot expand. So that's a closed chamber effect, which makes it extremely painful to the extent I've told you. People have equated it to the labor pain, and I've told you to the extreme extent the patients have gone to get themselves relieved. So please get this message. If the patient says I'm in pain, and if you diagnose it as symptomatic irreversible pulpitis, be rest assured that the patient is not flipping. He is in pain. This is the message which you must have in your mind, because then only would you empathize with him, that you would understand that he is in pain. And we do know the nerve blocks fail. You see, as far as the literature is concerned, in such teeth with symptomatic irreversible pulpitis, 60% of the nerve blocks fail. So we do now recommend that that use Articaine. It's more effective. We have literature. So switch on from lignocaine to Articaine is again what you would want to keep it in mind. And you would also want to understand that the biomechanical preparation has to be complete in these cases. Even if you leave a shred of pulp tissue there, then it's going to be painful for the patient in the next visit. Instruments don't matter. Actually, is the technique. Make sure that you master the technique during your program so that all the pulp tissue can be removed in such cases. And make sure that you have the right apical preparation size, as well as the taper which is required, which you would learn across when you would practice. And cardinal rules in such cases is that if you do not have the time, that because most of the time this is emergency, do not touch. You only touch that canal which you can debride properly, because if you do not complete the biomechanical preparation and leave the shreds of pulp tissue there, then that initiates a vicious cycle of inflammation, making it more painful for such patients. And obviously irrigation, you have to be case specific. Sodium hypochlorite happens to be the mainstay for such cases of irreversible pulpitis. And in cases with pulp necrosis, I've already told you that it becomes the second irrigation, the normal saline becomes the first, and you would need to follow it by the book. Single visit or two visits, Dr. Miglani was just discussing. Single visit irreversible pulpitis cases, yes, theoretically, yes, indicated, but it becomes quite tiring for the patient and as well as for you. But if you do have the expertise, there is no contraindication in symptomatic irreversible pulpitis. You can go ahead with single visit. But as far as non-vital with apical abscess is concerned, or non-vital teeth, please do not attempt it in single visit. It's nothing, something heroic to do such cases in single visit. You're only going to get up patients in pain. These are to be done in 2 visits, because you do require an intracanal medicament for the disinfection to be efficacious in such cases. Obviously, my last message is never leave the tooth open, please. I see it a lot of times in teeth with symptomatic irreversible pulpitis. Doctors leaving, dentists leaving the tooth so that they can relieve the pain. In teeth with abscess, they're leaving it open. Please do not do it. Do not develop that habit. It's only going to complicate your endodontic treatment. And when you complicate the endodontic treatment, your patient's perception towards you and your profession goes down. And now that's a very scary thing, which I would want you to learn out of my experience. Please make sure that you do the best possible for your patient. And the perfect endodontics is what you should always be aiming for. Always be aiming for perfect endodontics. I hope that you benefit yourself somewhere. I see one guy sleeping there very happily, but that's bad manners, I sometimes feel. But he may be tired. But if you get benefited here, I want you to translate that into your patients somewhere. Please learn something. You have mentors. Learn something so that you can transform it to your patients. They can benefit out of these lectures which we come here and deliver. And I don't know, these are just general dentist students, but you must know that the country is holding the first microsurgery conference in 2027. It just happens to be that the All India Institute is the organizing kind of institution, but it's the country's first, and whoever is interested in microsurgery, please be there in 2027 February. It's going to be a very interesting meeting because we have the father of microsurgery, Professor Kim, first time in India. He's never been here, and he's going to be doing live surgeries as well as of workshops, and he has a marathon half-day lecture. He actually speaks for the whole day, but since we have many more speakers, the second speaker happens to be coming all the way from Colombia. She only is very famous in the Spanish world, never on this side of the world she's ever come. She speaks on robotic and 3D dynamic navigation-based surgeries. Again, she's going to be performing a live surgery. And the third, Kim, is coming from Korea. He does a palatal approach for posterior surgeries. So please, whoever gets interested, I don't think so, is a chance to miss because they're coming to us. It's a country's first, it's a country's program, and I would want good participation from their side. Please, thank you for your patience, please.
Thank you so much, sir. May I now request Dr. Sonali Taneja ma'am and Dr. Dax Ibrahim to felicitate our chairperson of the session.
Member and Committee Chair of Singapore Dental Association. We're proud to have you, ma'am.
Namaste, everyone. Mera naam Jesslyn hai. And before we begin, I'd like to thank Cynodent and Dr. Anmol Bagaria and Dr. Ashish Chandra for inviting me to speak at this conference today, and basically giving me the chance to finally visit India for the very first time. So this is my first trip to India, and it has been amazing so far, albeit a little bit hot. And I'd like to show you guys some of my favorite pictures that I've taken so far on this trip. So I got to go visit Agra a few days ago to see the Taj Mahal and the baby Taj. And here are some of the pictures that I took there. And I found the architecture of both of these buildings so amazing. They're both such beautiful buildings, and I was just in awe of the craftsmanship and the history behind them. I even got to see some of the local artisans do their magic, and I don't think I've ever seen such beautiful marble inlay work. They were so intricate, and I also got to see some Zardozi handicraft as well. So thank you so much for this opportunity for me to come and visit India. Now, before I get into my lecture topic, I always like to start by introducing myself and giving a bit of background about me and the work that I do. So I graduated from the University of Melbourne in Australia, and there on the top right, you can see that's the hospital where I did my training, and on the lower left is our sim lab, and that was where we did all of our preclinical training back when I was a student. And I have always been very passionate about oral health, especially when it comes to raising oral health awareness among the general public. And after I graduated, I moved to Singapore and I started working there as a dentist. And there I would go to primary schools to talk to kids about brushing habits, give talks at community centers, and I continued championing oral health awareness when I became a council member of the Singapore Dental Association. So as part of my work with the Singapore Dental Association, I served as chairperson of the Oral Health Awareness Committee, and this gave me the opportunity to lead initiatives that brought oral health education beyond the dental clinic and into the wider community. So I worked on programs aimed at increasing oral health literacy for the public, including preventive education, public forums, community engagement, and collaborations with oral healthcare brands and industry partners. So this was actually a recent trip that I've just been on. This was in Borobudur in Indonesia, and I help organize this trip every year where we bring in dentists internationally to come and service the underserved community that lives around the Borobudur area. And it's a very, very fulfilling work, and we help to also raise the oral health literacy among the population there as well. So through all of this work that I do, I became increasingly convinced that dentistry is not only about treating disease, but also about helping people understand how oral health affects their overall well-being, confidence, and their quality of life. So how does this relate to our lecture today? Well, as dentists, we spend our careers looking inside the mouth. We see teeth, gums, restorations, implants, aesthetics, occlusion. But today, I want us to zoom out. The mouth is not just a site of dental disease. It is actually one of the most accessible mirrors of a person's overall health. It reflects inflammation, habits, stress, sleep, medication, nutrition, systemic disease, and also quality of life. So today I want to explore one simple idea. When we understand the mouth, we understand the patient better. And that is why oral health matters now more than ever. Okay, so let me begin with a question. When did you guys last ask your patients about their sleep, stress, or chronic illness? Let me see a show of hands. Like, who of us here routinely ask our patients this question in our practice? So not many of us, right? Well, very often, the answer is already in front of us. It may be in the bleeding gums, the dry mouth, the wear facets, the periodontal disease that seems worse than expected. Now, this is not about making dentistry more complicated. It is about expanding what we notice as a clinician. And it is about moving from simply treating teeth to reading health. So you can see some stats up there on the slide. 3.5 billion people are affected globally by oral diseases. And untreated dental caries is the #1 most prevalent non-communicable disease worldwide. And guess what? 90% of systemic diseases have oral manifestations. So you see, these are not rare problems, nor are they minor problems. Oral diseases affect how people eat, speak, smile, work, socialize, and feel about themselves. They also reflect inequality, because the burden is often highest among people with lower access to care and lower health literacy. So when oral health is excluded from mainstream health conversations, we miss a major opportunity. In a world focused on longevity and prevention, oral health is actually a strategic front door to healthcare. The mouth is a biological interface between inflammation, microbes, and systemic risk. And we see important links with diabetes, cardiovascular disease, pregnancy outcomes, respiratory infections, and emerging research in cognitive health. So who among us have heard about this thing called the oral systemic connection? Because, these are not just correlations. They are pathways and opportunities for earlier intervention, patient education, and more holistic treatment planning. So if the mouth reveals systemic health, then the role of the dentist naturally expands. Of course, I'm not suggesting that we can all of a sudden become clinicians and diagnose medical conditions just by looking at our patient's mouth. But what we can do is become better sentinels, educators, and connectors. The dental chair should be a preventive health checkpoint. Patients may come in for pain, whitening, aligners, implants, or even cosmetic treatment. But every visit gives us a chance to notice something bigger. And that is what today's lecture is about. The evolution from tooth treaters to health advocates. So here are 4 shifts that we can implement to become better health advocates. First, preventive healthcare. This means using the dental visit to ask better questions. Better questions about blood pressure, diabetes risk, sleep. Now that's a big one. Smoking, stress, and medication. Second, early disease detection. So make sure that during checkups, we do a thorough exam. We're not just looking at the teeth and gums only, but also look at the mucosal tissues and screen for oral cancer and sleep apnea. Third, patient education. So our job as dentists is not just to tell our patients what is wrong. It is to translate what we see into a language that they can understand and act on. I think most of us are pretty good at explaining risks when it comes to doing certain dental procedures, like root canal treatments or implants. And this is probably because this has been drilled into us since dental school. I mean, it's very important because we need it for informed consent. It is part of our patient management, and it helps us avoid tricky situations when things don't go 100% the way we intend them to. But how many of us put as much thought and effort when it comes to explaining the risk of no treatment to our patients? And we're not talking about, oh, you know, if you don't do a filling now, maybe you might need a root canal later on, or you might need to remove your tooth. If a patient comes to you with an infected tooth or perio disease and decides not to do anything about it, how do you think that will affect their overall health and their inflammatory markers? What if they're pregnant? Or what if they have cardiovascular disease? The ramifications go way beyond just losing teeth or needing a root canal treatment. And that is where holistic well-being comes in. We need to start educating ourselves and our patients about how the mouth is connected to the rest of our body. See, dentists have a rare advantage in healthcare. It is said that 60% of patients see their dentist more regularly than any other healthcare provider. And many patients avoid medical appointments until symptoms appear. But they may still come to us for a broken filling, a toothache, a clean, or even just cosmetic treatment. And that gives us access, and access builds trust. We have regular appointments. We have regular appointments where we can examine the oral cavity very closely. And through this, we build long-term relationships with our patients. So if you see, and if you really think about it, we are actually an underused channel for screening, prevention, and referral. Now here is a list of common things that we may come across in our clinics and what they may point to beyond the mouth. A patient with xerostomia and burning may need more than just a saliva substitute. We may need to think about things like medication, diabetes, Sjogren's syndrome, or autoimmune diseases. And gingival enlargement may not just be plaque-related. It could be linked to medication, blood disorders, or systemic conditions. And tooth erosion may point to reflux or eating disorders. And did you guys know that a scalloped tongue or signs of bruxism are usually linked to sleep apnea or stress? So these are things that we can look out for during our exams, and these are things that if we can find in our patients can be talking points to basically further patient education and also help us build better patient rapport as well. So how do we weave this into a conversation with our patient? How do we do it without frightening our patients? And how do we stay within scope, but still act responsibly? Now, these are some of the common questions that I get. And the simple answer is really just practice. Just like how we've become really good at explaining risks like, file fractures and implant failure, we'll get better at starting these conversations the more we actually do them. And these conversations are important because they have the power to change outcomes. And one thing to remember is that patients do not need more fear. So please make sure that there is no fear-mongering when starting these conversations with our patients. In reality, our patients just need context, clarity, and a next step for them to follow up on. It can be as simple as, I'm noticing persistent elevated inflammation around your gums. And sometimes this can be influenced by blood sugar or just general health. And I think this is worth checking up with your GP. Or you can say something like, your mouth looks quite dry today. Has there been any changes in your medication, hydration, stress, or medical history? Basically, what you can do is link your oral findings to a health concern, offer a referral pathway or written recommendation, and then normalize the conversation as prevention. So what can we do moving forwards? First, we should expand on our medical history, We should ask about sleep, stress, blood pressure, family history, diabetes risk, medications, and chronic disease. Be a little bit more thorough when we're looking at our medical history forms and follow up on anything that may seem a bit off. Second, adopt a whole patient mindset. Chart what you see systemically and not just dentally. And third, this is quite important for those of us that are already in clinical practice. We need to upskill our team. So your hygienists, therapists, nurses, and front office staff should all be on the same page and reinforce prevention and support consistent messaging. So they also need to be educated about these body and mouth-body connection as well. And number 4, we need to build referral networks. So do not simply refer into the void. We should create warm pathways with our GPs, endocrinologists, cardiologists, sleep physicians, dietitians, and other allied health professionals. So these changes, although they might seem foreign at first, they are not impossible. Okay, they are small shifts. But these small shifts, repeated across thousands of dental appointments, they can create real population health impact. So let me close with this. The mouth speaks before the body does, and every appointment gives us a chance to listen. We are not just dentists. We are part of the first line of defense in a world where chronic disease is rising, access is unequal, and prevention is often severely underfunded. So chair by chair, patient by patient, we can make oral health the cornerstone of holistic care. Because when we help patients understand their mouth better, we help them understand their health. Thank you very much.
Thank you so much, ma'am, for enlightening us. May I like to call upon Dr. Dax Abraham and Dr. Ashish sir to kindly felicitate our moderator, Dr. Vidushi. I would like to call upon our next speaker for the day, Dr. Amit Bhardwaj sir, to enlighten us on the topic, Role of Intellectual Property Right in Dentistry. For moderating this session, I would like to call upon Dr. Vidushi Shiokhan, Professor and Head, Department of Periodontology, SGT University. She's also serving as her second term as EC member in ISP and appointed as an Assistant Secretary of ISP.
Good afternoon, everyone. It's my privilege to introduce Dr. Amit Bhardwaj, sir. Sir has done his graduation from Subharti Dental College, Meerut, and post-graduation from Vinayaka Mission Dental College, Tamil Nadu. Sir has done PhD in periodontology and presently serving as Director PhD programs at SGT University, Gurugram. He has more than 17 years of teaching and clinical experience in SGT Dental College and serving as professor in Department of Periodontology. Sir has appointed as internal and external examiners for both BDS and FDS examination at various universities and served as various PhD guides and MDS guide. Currently, sir is serving in 6 ongoing research MDS dissertation and 5 PhD theses. He has 152 national and international scientific paper publication in his credit and authored and co-authored more than 20 books on dentistry. Sir has invited as guest speaker at various national and international conferences and chaired various scientific sessions at conferences. Sir is a fellow of International College of Dentists, IFCD USA, and fellow of Para-Fawcett Academy USA. Sir has done fellowship in microdentistry from MUHS Nasik and as a key opinion leader for osteum implants. Sir has patents and design registered under his name and serving as a periodontal scientific convener in Indian Society of Periodontology and executive committee member from last several years. So please kindly join me in welcoming Sir to start his lecture.
Thank you, Dr. Vidushi. I thank team of Maharashtra University, team of Pare-Fawcett Academy, Cynodent, Dr. Anmol, Dr. Ashish, respected Dr. Puneet Batra sir, for having me here for this topic which I chose to present in front of our young generation, because I personally think that this is the need of the hour. Day in, day out, we are doing so many things, so many writing, so many artistic work, so many literary work, but somehow we forget to utilize these rights which our government has given us. So I am here to present very basic informative lecture on role of intellectual property rights in dentistry. As she said, this is my history, PhD from SGT, then since 2008, I am at SGT University. So these are some very basic questions which I want to ask audience before starting my lecture. We will answer it later after my presentation. Just look at questions. IPR stands for, have you ever heard IPR before? If yes to question 2, have you ever attended any workshop, seminar or conference on IPR? If yes to question 2, from where you have got information about IPR? Whether IPR cell exists in your university or institute? IPR cell deals with what all? Do you know what any courses which you can specialize for IPR purposes? Have you ever applied for any patent or grants? IPR are applicable. After participating in this survey, have you ever got motivated for IPR or not? This we will see your answers later. So what is intellectual property? In basic words, intellectual property is that creation, any process, any machine, any device, any equipment, any literary work, any artistic work, which you or group of your friends have created, designed, imagined with your own intellectual. So this is intellectual property. Now, Government of India has given us rights to protect it. So that's why it's known as intellectual property rights. Every country has its provision. Our country also has this provision. So what is the importance of IPR? So as I said, once you protect any IP property under your name, you can utilize it in your purposes only. Maybe commercial, maybe sellable, maybe under your name, and you can use it for your resume purpose, you can use it for your interview purpose, and way ahead. So having an intellectual right property protected is very useful. You can make a goodwill if you have good understanding and good reliable market value for your brand. So what are IPR contains? IPR contains basically 5 things. One is patent, then copyright, geographical indications, trademarks, and designs. All these 5 items are covered under intellectual properties. As I mentioned, Government of India has given us these rights to protect. First is Patent Right 1970, Design Act 2000, Trademark 1999, Geographical Indication 1999, and Copyrights 1957. Now what is patent? Patent is basically any process which you have designed, any equipment, any item, any machinery which you have designed, that you can get it under your name from Government of India, and you will be patentee for that. But patent needs to be very new, very innovative, and non-obvious. Non-obvious means if you are explaining your idea to anyone, they will not say that they have heard it, this is already existing. So it should be very novel and very new. And if you are designing any steps, all things will be very innovative. So these are the 3 criteria to get a good patent. Any device, machine, composition, any tangible, novel, and non-obvious, as I mentioned. For example, in dentistry, if we take care of dental implants, companies have got patents for each and every small component of their implant, whether it is abutment, whether it is implant body, whether design of implant, whether shape of implant, or some are selling on the basis of properties of implant, like CA coated, BA coated, hydrophilic, hydrophobic, so many things are there. But all things are documented and patented by that particular company. So, copyright is a legal mean of protecting an author's work. Patent is over, now we are coming to copyright. Copyright means which you will submit to any journal. Suppose you submit your article to any journal, they will send you one copyright form. So, copyright basically deals with your artistic work. Any diagram, any workflow, any article, any book, everything comes under copyright protection. These all things comes under copyright protection. Literary work, musical work, choreographic, artistic, architectural, figurative, cinematographic, photographic, and anything related to. If you are using any musical tune for your presentation, you must take permission for the original creator of that particular tune. So that he or she can ask why, without my permission, you have used my music background or something like that. Similarly, as a dentist, when you publish your article and you have, if you have made some flow chart, some diagrammatic presentation in your, you can first register that particular design under your name, then you can submit to journal. Because once you write your signature on journal's copyright, everything goes to them. So if you are very much keen, kindly utilize your rights initially. So that is the importance in while writing your scientific work. Now coming to third point, trademark. Trademark is very important when it comes to private practice. If you are building your clinic, hospital, any nursing home, and you want to set up some good name, some logo, anything, please get it trademark registered. There are two things. One is trademark, that you have designed it, but one is registered. If R with the round means you have registered with the Government of India, then no one can use it. So to register a trademark must be distinctive, non-descriptive and contrary. Indian law, उस country के law से कुछ भी ऐसा derogatory नहीं होना चाहिए that government can reject. So kindly make sure that whatever you are making trademark registered, it should be as per the norms of Indian government. For trademark, Indian government has signed treaty, which is known as TRIPS treaty. So you can utilize common rights with our country, with other countries also. If you have registered your trademark here, it is applicable to everywhere in the world. That is the treaty which our government, under the TRIPS rights agreement, they have signed. So this is the benefit of getting trademark registered. I will give some examples. These are few products which you can easily make out which design is fake, which design is actual. Like similarly in dental sciences or your clinic, these are few examples of your visiting cards. If you have created card number 1 on the left upper side, some of your rival can use the same shape, same design, just making some color change. But if you have protected the design and the shape, the dimensions of the card under your name, he or she cannot use the same visiting card. Or say your board of the clinic. This is the example of Mayo Clinics. They themselves have redesigned their logo 3 times. Earlier it was Mayo Clinic, then Mayo Clinic Health System. Now third one is the latest one. So you yourself can upgrade your design, logo, anything in future also. This is one example of which Colgate has filed that some companies are using the wrong format of writing Colgate and they are selling their product under the name of Colgate Palmolive. So this is one example. On the right side, you can see Kids Bunny, it's written TM. So they have also registered trademark for their product. And trademarks can be registered under various classifications. You cannot simply go to office and say, Mera trademark register kar do. You have to give which classification, which device, which product, which sub-classification your product falls under. Club Dental right side logo is, your left side logo is as in India, whereas the right side, which orange logo is, which is a clinic in California. So name is same, but the entire design is different. This you can use. But if name is also same and design is also same, then it is a controversial. So only making trademark will not work. You have to register it. Obtain a trademark for your dental practice name can give a huge impact on your long-term branding. You must have seen clinics under the name of 32 Pearls. Anywhere in any city of the India, you will find this clinic, 32 Pearls. So once you have registered 32 Pearls under your name, no one can utilize it. Then keep a vigilance, means you can visit your website, others' website, Google, just type your name and time to time check whether someone is not using your name or some legal issues are there or not. So to be active on social media platforms, and before filing any legal complaint, kindly make sure with your attorney that he or she will get it totally well proven that someone is using your name. Otherwise, it will be a wrong situation. Family name cannot be registered under trademark. I will give you example of my clinic. This is my clinic in Gurgaon, Dr. Bhardwaj Dental Clinic and Implant Center. But this cannot be registered because family name anyone can use. Like for example, there is a sweets known as Agarwal sweets. In every corner of Delhi, you have Agarwal sweets. But that is not patented name or trademark name or anything. But I can save this with some different logo, some different, you can say, font size, some different color scheme. If I write Dr. Bhardwaj Dental Clinic in some italics and get it registered, that is possible. Because क्या होता है दूर से देखने में एक साइन से पता चल जाता है ये नाइक का शोरूम है, एडिडास का शोरूम है, नाइक का शोरूम है. इसीलिए अगर मेरा क्लिनिक फेमस है और वो मैंने उसका जैसे क्लोव का लोगो मैंने आपको दिखाया, दूर से बोर्ड पे दिखता है दैट दिस इज क्लोव्स क्लिनिक. Similarly, pattern of writing can be protected, but Agarwal Dental Clinic, Gupta Dental Clinic, that cannot be patented, trademark, because that has family name with it. Now comes to design. Design has nothing to do with the functionality of the device machine. It has to do only with the outer structure of the product which you have designed. In general, a design is the outer outlook. The definition of design as per Act provides that design means only the feature of shape, configuration, any lines, any dots, anything in three-dimensional form. It has nothing to do with उसके अंदर क्या है, वो काम कैसे करता है. It has nothing to do with that. Only outer structure matters, like the shape. The protection you receive is only for the appearance of the article, not how it works. Important for dentistry point of view is, once your clinic is well established, kindly make a good patient chart, good stamp, good your seal of your clinic, good flyers for advertisement, that everything design will be under your name if you protect it. Otherwise, you can tell any one of you, if you are clicking my picture or picture of my card, OPD card, and it is registered under my name, please don't misuse it. Otherwise, आप clinic के CCTV में देखोगे कोई किसी चीज़ की फोटो ले रहा है, कोई किसी चीज़ की फोटो ले रहा है. Then they will use same label, stamp, token, card or something which is available in your clinic. These all things cannot be registered under Design Act, which has emblem, any flag, any national monuments, etc. Shape of toothbrush is very good example of design patents. Companies are patenting the shape of the toothbrush. Bristle कैसे काम करता है, nylon का है, silk का है, that has nothing to do with it. Just shape, 360 degree, angulated, straight. So outer anatomy of toothbrush can be design protected, not the working of the toothbrush. So this is the best example in dentistry. These are various logos, various design cards which you can design, get it designed from your designer and protect it. Because these are available on Google. If I may use it, and the other clinic can also use it. But the thing is, if you have protected it, no one can use it. Design registration is very easy. You have to just file it, wait for it. If any objection is there, you have to clear the objection. If there is no objection, the examiner will call you at office. IPR office are there in 4 cities of India. They will call you. They will examine it. If there is some problem, they will give you some time to reapply it, and they will register under your name. Same is the process with patent and other things also, but there you will get more time to get it resubmission. Provisional time is there, but design is very easy to get registered under your name. Design is very easy. 1 month, minimum 2 months, you will get design under your name. Now comes geographical indication. This is the 5th thing. Geographical indication has nothing to do with, again, functionality. It has to do with where the things originate. As name says, geographical indication. So you have indication that what is the origin of that particular item. Indication of goods as originating, produced, processed, or prepared in specific geographical area or territory. An indication used to identify agricultural, natural, manufactured good originating in different territory of India. Like these are the examples: Darjeeling tea, Kachipuram silks, Alfonso Am, Nagpur orange, Kolhapuri chappal, Bikaneri bhujia. Name is the name of the place of origin. Government of India has given this tag, GI tag. If you go to Connaught Place, there are so many emporiums of state arts. Most of them have these tags because various part of India gives various geographical indication. Art कहीं का अच्छा है, कहीं के मसाले अच्छे हैं, कहीं का कुछ अच्छा है, कहीं का कुछ अच्छा है. तो that comes under geographical indication. But that also needs to be registered with the Government of India under Act. Now question comes, अगर मैंने clinic खोला आज से 20 साल पहले and I got it patented or design patented or something, how much it will give me right time to protect it? So it says for patent 20 years, design 10 years, trademark 10 years, geographical indication 10 years, copyright, age of the author plus 60 years. So if you have design patent, anything patented, and kindly keep these timelines in your mind. 9 years, 11 months, 29 days, you will be out, someone else can claim it. So make this habit with your attorney to refile it within the time limits. Various countries have various organizations, but the WIPO is the only central or national or international organization which take care of any dispute worldwide. India has its own, UK has its own, America has its own, each country has its own. This is the classification system which I was mentioning, IPC International Patent Classification. There are around A to H section, 8 sections and 75,000 subdivisions to get your item protected. See one example, dentist, and this is again one classification, cooperative patent classification. Dentistry products comes under A61C. This is the classification. If you see, this is the PDF which is available on the website of Designs and Patents of Government of India, and everything is mentioned कि किस product का किस category में file करना है आपको. So make sure with the help of your attorney, don't file this item under that item under this. अगर वो material है, item है, toothpaste है, brush है, कोई vaccine बनाई है, कोई you have made some equipment, some scaler, some instrument, kindly make check of this कि वो किस में fall करता है. Then only go for proper application. Preparations of medical, dental, toilet products. This comes under A61K. Various search engines are available. Google Patent is a very good engine. You will, if you have any idea, just write keywords and it will give you कि इस तरह का same item already patented है या नहीं. With number, with complete detail, PDF you can download, you can match with your idea. It will give you idea to tweak your idea. अगर already existing है, you can tweak little bit your idea before filing it. Because once you file it, you will pay the fee and that officer will match with the already existing. They will give you one letter, sorry, this is already existing. It will waste your time. So kindly make a habit to search before filing the patent. India has 4 offices, Delhi, Mumbai, Kolkata, Chennai. Website is also there. You can apply online also, offline also, yourself also, with the help of your attorney also. There are lawyers, patent lawyers, IPR lawyers. This is a specific category of lawyers which are trained on this particular topic. Patent flow is very similar to design flow. Only thing is, in patent, you can file provisional patent for first 12 months. You can revisit your idea, resubmit your patent application. If you get some idea, अरे मैंने गलत कर दिया, इसको मैं ठीक कर सकता था. You will get 12 months to revisit your idea. That's why it said 12 provisional months. This, you yourself can give some changes if you feel. Otherwise, same process, they will call you. They will ask you what is the novelty. You have to explain to their officers. IP officers are there at all these offices. And if they are convinced, they will give you your number, registered number. But if they find that something is similar, they will reject it also. And if you are not able to convince them that this is very novel product. So can I file my patent online? Yes, you can file. Can I file patent myself? Yes. Can I file provisional specification? Yes. Do I need to file first in India only? No. You can file in Australia also, you can file in UK also, you can file simultaneously also. How can one register for online? For that you need digital signature, which Government of India has this website. You have to first get your digital signatures approved, then only you can file the application. Otherwise you need to take help of attorney lawyer, IPR attorney. Digital signature taking is very simple. Controller General of Patent Office, you can apply it. They will issue your digital signature. Henceforth, you can use that for your application filing. Can any invention be patented after publication or display in public? No. Once you have displayed your idea to any public forum, any convocation, any conference, any convention, or any article, then you will apply it, then they will say this is already existing. So please make a habit, don't disclose your idea, first get it patent under your name, then only publish it. Does the patent office keep information? Yes, they will keep information secret. Where you can find information? So every Friday they release one information brochure. You will get to know कि इस 15 दिन में कौन से publish हुए हैं. Every Friday they release. Patent office website पे सब available है. Now this is one treaty which is Budapest Treaty. होता क्या है? Sometimes there is a लाइनिंग ऑफ माइक्रो ऑर्गेनिज्म, सेल कल्चर, जिसको प्रोटेक्ट करना या ऑफिसर तक ले जाना और उसको अप्लाई करने से उसका टाइम आने तक, दैट विल नॉट रिमेन वायबल. सो अंडर दिस ट्रीटी देर आर सर्टन ऑर्गेनाइजेशंस पैन वर्ल्ड विच यू कैन यूज फॉर स्टोरिंग योर biological tissues, etc. In India, we have this facility at IM Tech Chandigarh, where everything microbiological, cell line, culture line, you can get it stored until your turn comes in patent office to get it registered. This is again one treaty which India has signed. This means 150 countries are there. If you are patenting and the other country will give you respect, they will not give the same patent number, but yes, they will give you first come first serve basis model. Yes, you have applied in India, we will give respect. But you have to simultaneously apply in UK, US, Australia, whichever country you wish to file. These all countries are the part of PCT. Now coming to specifically to sum up with dental patent, we must apply patent for any innovative idea. For example, if you have designed some instrument, some equipment in your clinic, according to your need, you have bent it, you have designed it, kindly get it patented first. Any new process, अगर आपने कोई medication बनाया, toothpaste बनाया, mouthwash बनाया, उसका एक process है, kindly get it protected. Any medicated formula, local drug delivery, something like that, you have herbal drugs you have created, kindly get it protected. Any industrial innovation or any vaccine. Then comes copyright. Article you have written, book you have written, flow chart, diagram, schematic diagram, any artistic work which you have created out of your research, kindly get it protected under copyright. Trademark, your clinic logo, your hospital logo, your nursing home logo, anything. Design, your clinic's pamphlets, your clinic's letterhead, your clinic's stamp, OPD cards, etc. Possible reading, this is a very good article, Dental Patents in India, a decade-long review. These are some court cases which dental companies have filed against each other, just that someone is using their technology or just copying their technology. This is the CAD-CAM technology by Medit. Some implant makers have filed that design is copied, spiral shape is copied, or you can say composition is copied, BA coated, CA coated, SLA coated. So companies are after each other that no one can use their technology. Procter & Gamble also some dental light technology on the basis. Dentsply Sirona also filed case against. So all companies are very keen about all these things. Now what are the other importance of IPR? IPR means as you are in university setup or various accreditation agencies like NAC, NIRF, they will ask you what all you have done in last 1 year, last 6 months, last 10 years. So if you have done all these things, you have something to show to them. Secondly, it will add to your resume. Any interview, they will give you upper hand if you have 2 patents, 3 patents, 1 book, 10 articles under your name. Or if you want to start up, then a patent must be in your hand so that you will get fundings. I mentioned you, have you ever done any course? There are some online courses which are provided by Government of India. IITs are providing it. You can do these courses online to get yourself updated. Coming back to questions, and you will answer now. IPR stands for C. Have you ever heard IPR before? If no, then from tomorrow onwards, yes. If yes to Q2, from where you have learnt? From PFA Cynodent conference. If no to, no till today. If yes to question 2, from where? out of your own interest, any journal, any colleague, any university authority, you can say from conference. Please find out on Monday whether your university or your institute has IPR cell or not. IPR cell deals with patents, design, all of three, none of the above? All of three. Do you know about any courses of IPR by any organization? Yes, SWAM, UGC, NEPTEL, they are providing. Have you ever applied patent? If yes, very good. If no, kindly be very focused from now onwards. IPR are applicable only nationally, internationally, both, or it is a choice of inventor? Both, as per the preference of inventor. After participating in this survey, have you got motivated? Yes, no, by compulsion, yes, or will work in this direction? What is your take? Yes or no? Thank you. So my take-home message is, we must protect our rights and simultaneously give respect to others' rights. Thank you.
Thank you so much, sir. I would like to call upon Dr. Dimple Padave, Dean, GDCH, Mumbai, to kindly felicitate Dr. Vidushi ma'am.
Good afternoon, everyone. I take immense pleasure in introducing the speaker for the day, Dr. Aman Chaudhary. And I think we've been partners in crime for quite long. And we have taken loads of lectures and workshops together. But still, since it's a formality, and I'm sure many of you in the audience know him quite well. But let me just tell a brief biograph about him. He's a distinguished professor at the Department of Orthodontics at Jamia Millia Islamia in oral pathology. And he did his MDS from Pune in 2004. He has devoted himself to academia and research, carving a niche as a leading figure in forensic odontology, which is his topic today. His academic credentials include a postgraduate diploma in hospital management from National Institute of Family Welfare. He's a fellow of Indian Board of Forensic Odontology. His expertise extends to 3D and 2D facial reconstruction, a skill honed at the Central Forensic Science Laboratory, Chandigarh, and further refined through specialized training in 3D computerized forensic reconstruction at University of Tübingen, Germany. He's the founding secretary of the Indian Association of Craniofacial Identification and serves as the Secretary General of Indo-Pacific Academy of Forensic Odontology. Well, that's a huge list, and we've recently authored as editor also for the book on dental age estimation by Springer, very recent in 2026. Besides that, he has numerous publications, many citations, and his ITIN and HTIN index is quite high. So I think that's enough, because I can just go on and on. So Dr. Aman, please kindly.
Thank you. It's great to see so many people sitting at, somewhere after post-prandial lunch, so many people sitting. It's an honor to really host or be your speaker. Well, I start with a lot of things which are there. That's such a novel subject. First it was DCI, then it was NDC now. A subject which has been so naive, so novel, and we have been, I thank the organizer for giving opportunity to such a subject at such a great platform. I thank Dr. Puneet, I thank Dr. Anmol, Dr. Ashish for giving opportunity to present something which is so close. For so many years, I've been associated with this domain. My training already introduced to you. I have been trained at various places. When I was training, it was not as a trainer I was training. It was more of a passion because I didn't know where it will lead. I have been trained for not only forensic odontology, but for facial reconstructions, as well as, I have been associated with forensic medicine and forensic science people by virtue of my post which I hold, the office. So many of you are undergraduate, postgraduates which are there, and they have been listening to this word, and they feel that it is more of a Sherlock Holmes which they will be converted to. I differ in that. We are going to be giving scientific opinion, and it's not going to be so vague what we talk about. And a crude definition or a definition which is apt as of now. For when I teach students, I tell them application of oral and para-oral knowledge for civil and criminal matters, and I think that suffices much of them. I have been using it for the book which we have written, and this is a 2018 book which is there, and handbook available. I cut short my CV because there will be a lot of bragging about myself in my own lecture as well, because by promoting myself, I am promoting the subject as well. So this is next lecture is going to be on AI. So I've been using a lot of AI in my presentation, which you will see, and a lot of the tools which will be told to you in the next lecture in next 20 minutes will be visible right now, what you're seeing. So if you see, this is a whole slide which tells the history of forensic odontology, which you can generate yourself how you want. But if you see 66 AD to present CBCT, DNA analysis, all has been very fascinating. If you see histories, many of the lectures given by us are available online, which you can see that so much passionate work has been done. And out of that, 3 or 4 things we'll discuss. This is Oscar Omido. He is a Cuban dentist working and is also known as father of forensic odontology. He wrote a famous book which was there. And next is, a lot of Netflix will be there. This is in 1979, 2 dentists from USA fixed this person, Ted Bundy, who was a famous serial killer, who was fixed on the basis of his teeth mark. And if you look for a Netflix series, is also there. This is a typical, if you are third year or final year, you will be knowing what the impression is and how peculiar it is. And that time, not 3D scanning was there, so superimposition was not done digitally. It is done on an asbestos sheet or a modeling wax, which you can see. So excellent use of dental equipment, dental material was done. This is actually where the things complicated, because you have to keep in mind that on 11th September 2001, the world superpower was attacked and brought to knees, and we had 2752 deaths taking place and recorded, and victims were virtually received in severe pieces. And our friends tell us that more than 20,000 pieces were recovered, and they had to be approximated, and 1435 victims were positively identified. So you can imagine so many victims were identified on the basis of DNA, on the basis of dental and fingerprints. So, but keep that in mind, 78% places, so 78%, we know many of them were fixed by their identity was fixed by just dental records. So you can imagine what kind of a contribution you can do in a mass disaster. So coming to the history milestones in India, you can see right from Jayachand to recently Ahmedabad crash. So you can see a lot of a course which has been there. We have been applying so much of science. One mega case of yours can make you famous, whether it was Dr. Ashid or any person you know, Hemlata, or any doctors you know. They are all famous because of just single or twice case. So it is expertise, what kind of a reconstruction you know, what kind of identification you know, you can be there. So and they are, mind you, many of them are just BDS. They have not even they are trained abroad for forensic odontology. So I through this platform, the slate is totally clean. You can really go about doing your science, contributing. But why so much hue and cry about teeth? Because I tend to sit with forensic medicine, forensic science people, and we are just holding this much part of the body. What is so pride about it? The most pride about it is that each human has individual set of teeth that can be tracked, and no mouth is alike. So that is the basis of forensic odontology. Then the teeth is made up of enamel, which is the hardest tissue. It withstands trauma, it withstands immersion from water, it withstands heat, it withstands many tissues of your body which will not be able to do that. And excellent source of DNA. So whether what kind of a DNA which we'll discuss, see, I'll be rushing through 15-20 minutes. I'll just give you an overview what has been there. You can etch your own journey. So, it's an era of AI. The first thing I earlier used to search on Google, then I used to search on YouTube. Now I'm searching on AI. What are the attributes for a forensic odontologist? This came up, and I think that suffices what kind of skills you require. So, the civil, criminal, and academic research are required. Now, civil, matters of fraud, neglect, profiling, etc. Criminal can be recognized teeth by bite marks. Then academics can be, you can see this branch where there are periodontists, endodontists, there are orthodontists, there are oral medicine people who are there. You have to see, or even oral surgeons are there. So you can see the branch from your own lens. What are you trained in? What you can contribute to the subject? Because I've seen excellent endodontists doing forensic odontology work, prosthodontists doing by bar coding, etc. they are doing. So contributions can be immense. So core areas can be age estimation, which is 70% of the entire forensic odontology right now is doing age estimation. Human identification, which includes human profiling, bite mark analysis, cheloscopy, rugoscopy, and DNA and DVI. So I'll just rush through what we have done, how our journey has been. Age estimation. So ma'am just introduced, this is the book written by us, both, the chairperson and the guest speaker is actually the editor for this. So this book has 20 enormous chapters, and it has been a 4-year, 5-year journey for us, and these names which you see are inventors for various age estimation programs, various age estimation ways, methods. You can see right from Emilio to Bedek to, these Bedek formulas are there to really go about seeing how age can be estimated from a simple OPG. So you can imagine what kind of a science went through for last 5 years, which we published in 2026. Why dental age estimation is so important? It is important. Why? Because it helps in determining the chronological age, which is actually the DOB which you talk about, date of birth which you talk about. Then it assists in forensic identification. See, for you it might be just a why to spend so much money, so much resources on that. Imagine a mother waiting for a son which had died 20 years back. She will keep on waiting till her last breath. So the closure of case is very important in forensic odontology. So you have to keep in mind that you are contributing a lot when you are doing something like a closure. There are cold closures, there can be closures because of the insurance aspects. Various aspects are there. So you have to really, the kind of science which is being used is enormous now. Then supports anthropological thing which are there, then provides relatively, non-invasive methods are there, because just by an X-ray you can really tell, whereas for a DNA you might have to cut open a tooth. So, this can be a really turning point in cases where medical officers do not allow you to touch the body itself. Classifications are there. Classifications can be based on this. I personally, if I want to write an answer, I put this question, classification, I write through this. But if somebody asks me the compiled way, this is an article, beautiful article where he has compiled various methods, and many of them are perio people, endo people who have actually invented these methods. They have been doing it clinically. They did not realize that they are doing so much for mankind by inventing such things which can really tell you what can be the closest chronological age of an individual. And many of them are orthodontists, and one of them, Dr. Nanda, he is also one of them who actually, being an orthodontist, invented the growth and development pattern. He did not realize that he's not only contributing towards his subject, he's contributing towards forensic odontology as well. These are the mind maps which are there for how to go about doing age estimation, what methods are available. This is the London Atlas, and if just skip through, this is Demergen. These are the two methods which can be done on OPG. It happens to be my PhD topic, hopefully completing this year. So London Atlas is available online. If you go about it, just put your OPG, just put what kind of growth pattern you are seeing, and you will get the age. So this is so simple. Of course, you have to have an eye, you have to be trained for that. It's freely available. Both the people died in 2026, very recently, whether it is Al-Qatani's London Atlas or Demergen. And by chance, they are my PhD subjects. So we conduct workshops on Demergen. Madam sitting next has been the inventor for this chart. This is the Demergen DAECC chart, which is there, and it has been tried in various countries. If the stage is open, if you really want your population to be tested for Demergen, we can really provide you help in that. We have enormous, you'll be seeing in identification part of mine, which I take for 3-4 minutes. You will be seeing what kind of publications we have gone through. And definitely, when I entered oral pathology, very few people were there. When I entered forensic odontology, very few people were there. Now I'm entering dental age estimation. There are very few people there. So I suggest, please divert your resources toward it. Human identification. Now, in a 30 minutes or a 25 minutes lecture, it is very difficult for me to tell you how to go about identifying an individual by dental traits or dental anthropological methods. So what I did was, I'll just tell you what has been my journey, what we have done. Dental evidence is one of the most reliable methods for human identification, especially in the means of identification are unavailable. Why they are unavailable? Because you cannot match. In an Ahmedabad blast, which body to match with what? If it's a closed blast, if it's a mutilated blast, if it is a burn blast, or it is a immersion of body, it is very difficult to get a correct DNA. And in a country like India, where body can be found any place, it is very tough to actually locate which DNA to match with that. And that time, dental and craniofacial structures can play a very vital role. And just you can imagine that what we are doing is just like a iPhone seeing, just by your face, it opens. So that's what we do. Actually, we try to superimpose, or we try to reconstruct an identity just based on biological features of the face. So applications of this can be done, why identification can be done in cases of deceased, in cases of DVIs, in cases of criminal investigation, missing persons, and identification of burned, decomposed, and skeletalized remains. So if you see, there is a comparative identification and a reconstructive identification. Comparative identification is done abroad. Why am I saying? Because antemortem and postmortem records are available. They have a family dentist, you tend to ask for an OPG, you will get. In here, where the local anesthesia is given by somebody else, the root canal is done by somebody else, and the payment is taken by somebody else. So you don't have a record. So it is a tough job, and you keep on changing dentist as per your payment pattern. So you can't have a kind of an antemortem record. So what we do is a reconstructive identification, and it's a tough job. What we are doing at Central Forensic Laboratories, Chandigarh, or maybe Central Forensic Laboratories at various places. It's a very tough job because they get cooked food, they just match and they give an identity. We have to invent an identity. So that is very important. And with with so many associations coming up, we actually propose for a centralized repository for OPGs and these kind of the data which is taken. And when even Aadhaar is an issue, getting a OPG in a centralized position, people might object, might be there, but for a mankind, for kind of a science which we are doing, this can be really helpful to us. Talking about something called as these charts which we do, these are done manually. This can be done electronically. The red chart is antemortem, postmortem, and then the yellow chart is antemortem. So what we do is we take the OPGs or X-rays or wherever whatever information we have, we fill in the yellow, and whatever is there present in the dead body, we fill this. If these two match, the body is correct. And it might appear very fascinating. You one wrong step and you will give wrong body to another one. That's happened in India. So just keep in mind, what is appearing very fascinating to you might lead to, your career might be over. If you give a terrorist body to a martyr, you can imagine what will happen. Where in a country like India, where burying and burning a body is a big deal, you can imagine what can happen if you give a wrong body. Coming about, just telling you how we went about. These are a couple of publications which are there, and you will see the madam sitting next in many of them, because she happens to be an orthodontist. And the team members which I have are mostly from other branch, because I'll be contributing from my branch. Of course, I'll not be replicating myself, but you will be seeing that a person from perio, pedo, they are contributing from their own lens. Like if a case of child abuse is there, I cannot be a specialized person. I can take a seat back. She can be contributing. And definitely why orthodontists are there, because they are the best people maintaining the records. They have the best records available. So that is a gold mine for us. X-rays with them, of course they work, but they have a pattern of working. We, being a dental anatomy person, we have different pattern of working. So this is an image manipulation which we published 2014. We manipulated the image and we tried to superimpose, and we saw how forensic odontology can be tweaked. And what are the methods we can stop for that. Then rugoscopy chart which we gave, we invented in Jamia, where we conduct workshops also, how to go about classifying rugae, and we are about to automate it also, so that you just put a rugae picture and we can tell you whose it is. It is kind of a biometric thing which we tend to invent on that basis. Then IBFO experience, of course, we are trained in that. Comprehensive chart, we have we have the chart which we showed you. We have tested it in various populations as well. This is facial reconstruction, which we talked about. I've been trained in Tübingen University. I happen to be very few people who have been exposed to this haptic feedback, where you can touch the skull by touch the craniofacial structures just by holding a pen to it virtually. Now, this is FFA, the contribution of orthodontists, what they can do, how they build a nose, how they build a lip. They have already done it for smile designing. We were trying to put that science in the field of forensic facial approximation. Salivary signatures, systematic reviews, evidence-based. We have tried to inject everything in forensic odontology to promote the subject, whatever we knew, right from bibliometry to systematic review to meta-analysis. We have tried everything so that we are the whistleblowers for forensic odontology. If you see, we have tried to collaborate with abroad also, that we have what kind of a dental anatomy they are doing. We are since 25-30 years we have been carving crown, we have been carving root, wasting a lot of wax, which people have really moved on from that, from hologramic structures to just carving a crown. We have suggested so many. If you search us, we have been trying to object that so much hours are there, and that too, for a root carving at least should be deleted from the curriculum. We have written it, but I do not know. There can be reasons for not deleting it, but definitely so much weightage on that should be really not there, and it's not done abroad as well. So we have worked on ACUDRs, that is the Arizona State Dental University caste system. Now this is actually for dental anthropology. You have been learning cusp of Carabli. You've been learning shoveling. You have been learning. You'll be learning different kind of cusp pattern which are there. They're all there. 20 traits, non-metric traits are there. Just by matching, you can tell what kind of what kind of a ethnicity the person is having, whether he's a Mongoloid, whether he's a Caucasian, or whether he's a Negroid origin, or a mixed one. Like in India, it is very difficult to really predict what kind of a thing is there. Now, this is another publication which happened. We have had massive publications in forensic odontology. Why? Because the slate was open, the stage was totally open. We do not, and we lack in data. And in spite of being 1.4 billion people, we have very less data to really publish in forensic odontology. So coming to bite mark analysis, I'll be really fast about that. That bite mark analysis has been really condemned throughout. There is something called as so much condemnation. If you search bite mark, so much negativity was spread. It's not because bite mark is bad. It is because your science has not developed right. You have been giving too close. You're not knowing how to write an opinion. You're not knowing that it is like that. Is now you will never see a dental anatomy person writing the age of the cast is 9 years. He will never write. He will write 9 to 12 years. He will always give a range. And that's what is not saving you. It is saving the individual as well. You have to keep the corroborative evidence also next to it. You cannot be, the first sentence I tell who is training under us is, we are not Sherlock Holmes. We are scientists. We are giving opinion. We are not giving verdict. So be in your data which you're presenting should appear that way. So if you call this, this is not a bite mark. This happens to be from snake, actually. We do not have a two-thing binding in that. And that is not how you take a thing. The picture is taken this way. There are various ways. You have to be trained in, photography as well, because photographic evidence is very important. There's a close view. There is what kind of pictures you want to take. There's a bite mark analysis. This actually helped because I was totally trained in CorelDRAW, so it was 5 minutes job for me to learn bite mark analysis. A person who is trained in some kind of a high-tech thing, it will be very easy for you to really get trained for such equipment. DNA. So fascinates a lot because a lot of people research is happening in various branches as well. So me being an oral pathologist have been exposed quite early. So teeth are an excellent source of DNA and can resist extreme condition, and that is the basis of using DNA in this. The PCR allows the amplification even at highly degraded DNA can be amplified nowadays. The pulpal tissue is the best source of DNA, and types of DNA can be genomic, that is a nuclear DNA, and there can be mitochondrial DNA. So I'm not beyond the scope of the lecture to really tell you how to go about DNA. Just keep in mind that we are the providers. There can be forensic science people who will be excellent at that work, but who will provide without damaging the DNA? We are the people who can cut open the tooth in a way which we have been taught since first year. And that is the same for facial reconstruction. People who were training next to me were not knowing the figure of 8 mixing. They were not knowing what kind of a material is being. The material which is being used is alginate, which we start using in first year. So my training became quite easy and gives pride that, that made me write an article which you see that, forensic oral pathologist or a dentist can easily be a part of forensic facial approximation team. So we propose that in Belgium. So, take-home message, clear, it can be your journey. You are trained as a BDS, you can give opinion, you can be a medical officer. So somebody asked me what training I require, BDS is enough. Now comes, what are you trained for? A good BDS who is trained in first year is actually telling just by seeing a cast age. And that's what we do as a Shaws and Moslers. So we go one step further, we use an X-ray. Then we go one step further, we start using enamel. Then we go one step further, we start taking a ground section and try to see the cemental annulation and do a Gustafsson method. So what you are doing is the basis, and you have to be trained further. There are institutes, there are associations which actually help you in training. You can go about search. If you have any doubt, anything, you can scan that and reach me if you want. I have a lot of AI, I'm sorry. The stage is open still, and a lot of people are doing forensic odontology now. So before you miss the bus, it will be great if you are trained in it. Thank you so much. That's my time.
Thank you so much, sir, for such a lovely presentation. To felicitate our moderator for this session, I would like to call upon Dr. Dax Abraham, sir.
She is an adjunct faculty at Department of Orthodontics at D.Y. Patil Dental College and Hospital, Pimpri, Pune. She has completed her BDS from Government Dental College, Patiala, and done her MDS in orthodontics at AIMS, New Delhi in 2006. With over 2 decades of academic and research experience, she is committed educator and researcher in orthodontics and dental sciences. She has attained her fellowship in forensic odontology in 2018 and ISDR in 2023. Her key research interests include evidence-based dentistry, salivary gland diagnostics, translational orthodontics research. She has co-authored 60 publications, 10 book chapters, and 1,500 citations, including several systematic reviews and scoping reviews. She also served as an editor for Springer Volume Dental Age Estimation, A Global Perspective, 2026. Dr. Kapoor holds 2 design patents, 3 copyrights, and is a recipient of prestigious Moore Symposium Award, Michigan, USA. She received her 3M Unitech iOS Research Grant 2020, leading development of OSA risk management tool mobile application. She actively contributes in interdisciplinary research, diagnostic biological mediator research, including microRNA in saliva and GCF, particularly in mandibular condylar cartilage growth, and OSA risk assessment in young patients.
So I think this is the last lecture, but actually it's not a lecture. Sitting here, I was wondering, my topic is AI in learning and research. And the last 3 rows or the last 4 rows, I think they know more about AI than any of the first 2 rows here of the faculty. So I think we should interchange our positions, and you should be coming here, teaching us AI, and we should be listening. But catch point, why I'm here? Because when you start using a thing, first of all, you should know how to use it ethically. Because right now, if I ask anyone here, when was the last AI you used? Maybe 5 minutes back. For anything. And ChatGPT, I think it's a go-to for everyone, for everything these days. And in the morning also, when I was in my OPD, I was just asking my students, where do you use the AI? Generally. So for them, everything go-to is ChatGPT. So yes, knowing how to use AI, maybe you are the best people to tell us. But how ethically to use AI in learning, teaching, and research, maybe that's why I'm here. A small contribution, let's discuss some things. So I'll be primarily covering in these broad topics, why AI matters. Actually, I'm not going to tell what is AI because everybody knows. So there's no point in discussing that. But why it matters is important because for everything that you start, your why is most important than how. Anything in life, if your why is strong, how will automatically come. So yes, why we started using the AI was because in 2000, if you see, there was information scarcity. You know, all of us in the first 2-3 rows, we have done our MDS at the times of 2000, 2003, 6. At that time, if we had to search something, well, National Medical Library, that was the place to go to. And we didn't have anything on the computers at that time. So yes, we were bound to go and search for everything. So yes, we made a practical note of actually going to the libraries, which you guys don't do, which you don't have to do. I'm not saying that's a wrong thing, but you don't have to do now. So yes, ever since 2000, if you see the progression, we have abundance of information. But how to extract the information that is important is now that we have to learn and we have to practically apply it. So here's our roadmap. Actually, this is again an AI-generated chart, definitely, because we are doing a lecture on AI, so why not use the AI where we have to use it? You know, even Dr. Aman showed you one picture in his presentation that was made by AI. So if we used to do our presentations like 5 to 6 years back, it used to take a lot of time for all of us as faculty. I'm sure they all resonate here. That if we have to compile anything, you know, even in our presentation, it would take a lot of time because we would be extracting information from 1 source, 2 source, 3 source. But now we have to put the suggestions in the AI and we have to just give the right prompt, that is prompt engineering. I'll be just using the keywords which are important for all of you. So prompt engineering becomes very important, and there, this is the AI, this is what the AI has given us, all in one chart. And if you just go home and see, and practically again and again, if you use it, you will come to know that all information is in front of you, right in one chart, which was not possible before. So yes, if we try to use it, I've just, for the purpose of learning, for teaching, what are the recommended tools, where it helps, and the examples that are given. I can purely share the slides, there's no problem, because it's nothing that I have invented. I'm just telling you how to use it ethically. So yes, where all we can actually implement AI. So if you go from the hierarchy, as a student, from the back we come to the front, because I think many of the speakers here have told the students to come forward, but they're not ready. So let's go from back and come to the front. So if the students, they practically use AI more in the academic front, I'm telling you, for learning purposes. And for the faculty or the postgraduates, they use it for their thesis, for their dissertations, for their case presentations, so primarily for research purposes. But for the faculty, I think, we use it at every step. We use it for the formative assessments, we use it for the summative assessments, we use it for our teaching plans, we use it for our timetables, we use it for our giving our thesis topics, we use it multiple ways for the research as well as for the clinical case presentations. And for the institution, definitely, and I strongly recommend, Manav Rachna is a beautiful institute. And, you know, I feel it's like homecoming for me. So the suggestions that I give here is like I would give to my own institute. So yes, the curriculum development, I think we should mold or tweak our curriculum in such a way for the undergraduates as well as the postgraduates. AI is here to stay. There is no doubt about that. So if we incorporate AI in the right way at every curriculum steps, I think that is first and foremost that we need to learn. AI in learning, if you see, well, I just take an example. My expertise is orthodontics. So yes, I've just taken one example of how would I give a prompt, okay? So if I'm giving it for UG, I would just say, explain growth modification in class 2 malocclusion to a second year BDS students. So I'm actually used to walking, so I tend to come here, then I again tend to go back. Anyways, so if I have to give the right prompt, everybody knows a PICO format, right? that is participant, intervention, comparator, and outcome, right? But if you have to give a prompt to the AI, how you would give? I've actually included that article also in my last slide. It's a beautiful article, and it just tells you how you can tweak that PICO into the prompt engineering concept to give the right prompt to the AI to get you the best answer possible. So if I just write on the AI that explain growth modification in class 2 malocclusion, what do you think it's going to give me? It's going to give me a hell lot of research papers, and the jargons that maybe a BDS student would not understand. So I have to say, what is my theme? It is a class 2 malocclusion, growth modification, and for what? For what population or for what participants I'm going to use it? It is for BDS, second year student. So the AI will actually give the information based on how the BDS second year will understand. But again, if I take a second example, these are the two dental age estimation methods most commonly used, Demerjian, Willems, and Camaraderie. So if we have to give it, we have to tell the AI that you can, but then I won't be able to change the slides, right? No, slides sorted, slide changes. Okay. That's okay. She'll change the slide for you. Now can you hear me? Okay. So we have in the second example, if you see, we have 3 age estimation methods. Now in these 3 age estimation methods, I want to actually compare, I want to prepare a table, and I want to do a comparative analysis of all the 3 age estimation methods, but for a postgraduate student. I can also give it for an undergraduate student. I can give it for a faculty research. I can give it for a PhD research. The answers would be different. So I told you in the start of my lecture that I was talking to my BDS students. So I asked them, how do you keep the prompts? So they just said, ma'am, if we have to learn something, we just put the topic. So the answers that come are beyond their level. And in fact, they also tell me that the answers that come are not at all cohesive. One title there, and they're not able to correlate. So please, that's a request that I have to make. Use AI for learning. There is no problem. But AI cannot understand unless you give the full context to the AI. So what I would do if I would be a student, I would tell that I am in this particular year of my dentistry, and I have this much level of experience in this particular topic. Now this is what I want to learn, and I want you to tell me. I also have to give a theme, a format. I have to tell them that I want to use it for a learning purpose, or for memorizing purpose, or for tabulation. I have to give the whole context to the AI, only then you are going to get the right answer. So this is just example that I want to tell you. Then you have the key AI tools. This is, I think everybody knows. So ChatGPT, Gemini, Quizlet, Claude, Notebook LM, Elicit, and Consensus. So of these, I've just put the tools which are primarily free. So you can use them. There is no problem. But in Consensus, if I have to tell you, quite a few features are free, but when you try exploring it more, it is definitely going to ask you $20. So that's up to you if you want to pay. But personally speaking, ChatGPT is something that you should use if it's for a normal conversation tone. I mean, normal learning. But if you have to go more scientific, or for the image analysis, there is something called Nana Banana in Gemini. That's a free tool. Very beautiful images you can create. I really feel for the faculty who's present here, including me, because when we were learning, I think anatomy, if you remember, we just had those dissectors. And I used to go to dissector just to see the figures. They were so explanatory. I used to love dissector for anatomy. But now, you have your own personalized dissectors available to you. How much ever level you understand, you can just tell AI, I want a figure related to this nerves, vessels at this much millimeter. Even you can go to that extent. So that is your own personal tutoring assistant for you,
which was not available to us in our times. So I definitely agree that you should use these tools if you're using it ethically for learning purposes. Quizlet, yes. Before you appear for any exam, I think in oral pathology, Dr. Aman would say that for every topic they take Viva after every topic. So after every topic, when you have to prepare that Viva, why not go to the AI and just tell them what can my teacher ask me about this, or what can the MCQs come about this topic, so you can be well prepared beforehand. So it's very good, you know. And Claude, yeah, I've recently started using Claude. It's beautiful. For deeper reasoning for faculty, primarily I'm telling you. Maybe it's not that important for you, but for faculty, it's beautiful. For deeper reasoning for any particular topic if you want to go. Notebook LM also we've recently started using, and it will be beautiful for our assessment purposes also, if the faculty has to prepare the assessments. For elicit, definitely, because we tend to do a lot of evidence-based reviews and we want to do a lot of systematic reviews and scoping reviews. In that, elicit is beautiful because it will compile. You can take a PDF, you can put it into it, and you can tell elicit to explain that. So many a times we've done scoping reviews, and I think Dr. Shipra is here from Perio, and she also does a lot of evidence-based. And I think you must see a lot of articles, 130 articles if they are there. You can't expect us to read every line of it. So you can just put those articles and you can just tell the, the software to just explain or summarize, or even if you have to do the data extraction in that, you can just say, okay, summarize the material methods, you can say summarize the discussion, summarize the results. So it can be that explicit, which is not possible manually, or which takes a lot of time manually. Consensus, yes, you can start using it as I said, but if you want to go for a deeper thing, then you have to pay a lot of money. AI in teaching, if I say again, so this is beautiful. So if you have, for the lecture preparation, I can just say, create a 1-hour lecture on mandibular condylar cartilage growth. So now, is the prompt wrong? It is wrong. I never said for whom. I didn't tell the AI for whom. So अगर मैं 1 घंटे का mandibular condylar cartilage growth पे lecture लूँगी, तो वो तो BDS level का होगा या PG level का होगा, that I have to decide what I am planning to take. But it is so simple now, because earlier for one lecture, every faculty here would spend at least a month preparing for it. But now we have our concepts right, and we have softwares like Claude, we have softwares like Elicit and Notebook. Notebook is beautiful in this. You can just put the whole PDF of the book there. Profit you can put, and you can say extract that chapter and now prepare a lecture. It can do that, but never go blindly with that lecture, because AI is known for hallucinations. वो कुछ भी गलत दे सकता है आपको. So you always have to check. Once that result comes, you please check, cross-check again, and then definitely you can present. And the visual representation that the AI gives you is beautiful. You know, all these visual representations that the AI gives, if we prepare a master slide ourselves, it takes a lot of time. So yes, again, that's a beautiful aspect of a visual representation of any particular topic. So you can use AI for that. Then competency-based questions, if I had to say, according to the Bloom's anatomy, yes, it's not a time to discuss that. I'm keeping a track of my time. Dr. Aman is giving me looks, so I will keep track of my time. But yes, so according to the Bloom's taxonomy, the highest level is when you can apply that. So you have all the principles, you have all the learning objectives, you have all the matter, you have the content, you have organized it, you have prepared a presentation, but now you have to actually apply it. That is the Bloom's taxonomy. So that you have to generate the competency-based questions. If I take an example, then definitely it can help me prepare those competency-based. Again, I have to specify which competency I'm talking about, at what level of competency I'm talking about. So it can prepare according to that. Then sample prompt can be review the student answer. For, as I said, for assessments you can use it. You can just put the PDFs of, in fact, my writing is so bad. I sometimes wonder if I write something and I put my own PDF, will the AI be able to understand? But I've tried that and it understands. So yes, for assessments also, This is very, very important for us. AI in research, again, I'll not miss the term that it's very, very close to my heart. Because we've been doing research for the past 20 years now, and we definitely in our every lecture, in every aspect, we promote this because we are an audience of thinkers here. So we don't just have to blindly follow, blindly do anything. So yes, the research basis is very, very important for research question, protocol designing, scientific writing, literature review, statistical analysis, publication. All these, I have given the examples where you can use, what all softwares you can use. That's for an example. But you can try more softwares if you want. This is very interesting. Statistical analysis, I'm very of stats. So yes, when I got to know that I can use Jamovi, or I can use the JASP or ChatGPT also, yes, I started asking ChatGPT, this is my study design, these are my sample populations, what is the best statistical tool to use and why? So I started understanding the concepts in a very childish kind of a way because I'm really scared of stats. So yes, if you want to actually learn things at a very basic level, which maybe your instructor is not free to do or maybe he's also not equipped to do, so yes, this is your personal assistant. This is very interesting. So podcasts and micro-learning, this is the last concept that I feel is very, very important in current times because anything that like we are discussing here, now this becomes interactive. So every time I won't be present here, every time you won't be present here, but this AI, yes, it would be present. So how I started experimenting with it, take the most dry subject, which you just don't want to open the books for. You know, my PhD topic currently is microRNAs in functional appliance therapy. I don't know whether any of you understand that. Maybe some of you understand that. But supposed to be a very dry topic. So, I started experimenting on it and I thought that why should I not tell Claude that this is my thesis topic and I give my thesis is almost complete. So I gave the whole context to the AI and I said, now you prepare a 5-minute conversational podcast on microRNAs in functional appliance therapy. And, it was one-on-one conversation, very interesting. They were asking questions like, how do the TMJ works? How is the condylar cartilage formed? And the answers were to and fro. Everything from my thesis. I have given the input. But the conversational tone was so interesting that you as students or anybody who's listening to it, you won't get bored of it. So it's really interesting if we can just adopt that. But yes, as I said, I'm here side of the stage because I have to tell you that I've all shown you all the brighter pictures of AI. But yes, there are problems with it and we need to identify that before we start using it. So yes, there are hallucinations. It will give you all sorts of answers sometimes. So yes, you have to weigh what all to use, what all not to use. And something very interesting, I'm sure everybody of you have used. So when I start researching for a topic, sometimes I say, okay, this call has come, maybe an ICMR call or something has come, and I'm thinking of putting something on a liner. And I give the AI prompt that, okay, this is a topic related to aligners which I'm thinking. The AI will not even read. Within 5 seconds it will tell, such a beautiful topic, very nice topic, you should go ahead. I'm sure everybody will. But please don't trust that. No, completely wrong. Because the AI has not searched. And it is just telling you, go ahead, go ahead, go ahead. You should search the literature first. Whether it has been done, whether it is viable, whether it is not. Don't blindly rely on AI. No, never. Then fake references, many a times. Those references don't even exist. So sometimes I put it on the AI. So I only take my examples because I keep on using it and I keep on failing in it. Then I again do it. So I put some references, half reference, okay, because I don't know the full reference. So I say, okay, you retrieve the full reference with page numbers. वो मेरा ही नाम उसके अंदर डाल के, मेरा ही नाम उस आर्टिकल के अंदर डाल के और वो मुझे पूरा रेफरेंस दे देता है. So I definitely know I have not written this article, so it's a fake reference. But many a times you will get fake references. So please don't decide to trust AI on referencing at least. Bias in data, yes, definitely you can't generate data. Study to karna hi padega. Data cannot be generated from there. Privacy concerns, yes, if you're using something, you have to see that you can use it generated by AI, you can use it in your manuscript or not, or you have to give a disclaimer that it has been generated by AI, especially the images and all. Copyright issues, you should not be using anything which is copyrighted. And cognitive offloading, okay, this is something that AI in cognition, this is something which was bothering my mind because I've been not related to dentistry students, but in students in general, in our kids, they are in schools. So I sometimes think that even for their homeworks and all, they're using AI. I mean, like, is that healthy? I'm sure everybody of you would be thinking that. कि उनका तो cognition ही चला जाएगा. They would not be able to memorize anything. That's a fact actually. Cognitive decline is a fact. But if we use the AI properly, you know, it can also boost our cognition. Because sometimes, in our times, we were told, पढ़ो, रटो, एग्जाम दो, आ जाओ. Concept आपका clear हुआ है कि नहीं? कोई matter नहीं है. Now, if I am good in mugging up things, I would get good marks. Some person who is not that good in mugging up, but still understands the concept, will not get that many marks. So now, what I am thinking is that instead of cognitive decline, if these students use AI properly and go into the depth of any topic, I'm sure it is going to boost their cognition and not lead to a cognitive decline. This is something futuristic. You can have AI in future dental school as AI tutors, virtual patients, research. I'm sure many of these things are already being applicable. ये तो चल ही रहा है. Like while I'm talking, दो AI tools अभी भी कुछ introduce हो गए होंगे. So yes, this is all possible. But skills every dentist should have. Critical thinking, very important. Like I said, please don't blindly trust AI for anything. AI literacy, very important. This is like a first step that we are taking today. We are discussing here. The faculty is here. The students are here. So I'm sure this is the first step towards AI literacy. Evidence appraisal, ethical judgment, human communication. Human communication, you can't replace that ever. Even with the podcast thing. You always should have a human communication where you can go with your ideas, you can go with your doubts, and you can clarify. So never, never, ever severe communication with your mentors, with the teachers, anyone who can give you any information. So this is like demo 1, AI personalization. You can explain twin block to a 12-year-old, then explain same to an orthodontist resident, just an example. So the answers will be different. For notebook LM, as I said, you put your published paper, then you show, and as I said, you generate an AI podcast. This was really interesting. I had fun doing it. Metacognitive prompting live, what misconceptions, this can be done in Claude. So just 3 examples I'm taking. You can go and try it on your own. That's okay. But this is really interesting. You can quiz me. For every step you can say, now you quiz me. So even for our manuscripts, I've realized, now when they go for reviewer suggestions, so the suggestions that come back, वो completely एक chat GPT form में होते हैं. So maybe the reviewers are using chat GPT for giving you reviewer comments, so why not apply it beforehand? Why not give your paper before sending it for publication to the chat GPT and say that I'm a reviewer of this paper, now you give me comments. You correct those and you send those. So that will be a step back, but it will be for correction of your manuscript even before it goes for publication. This is the last slide. This is a beautiful article. Please go through it. It is basically for medical librarians, but I'm sure every one of us can use because we are used to a Pico format, but how we can tweak it for the prompt engineering, for giving it to the AI. This is the one, and it has given a format of TCEPT, which is task, context, format, and tone. So very interesting. Not is the time to discuss, but so this is a small topic the small discussion that we had, and I think I completed it on time. And this is the last lecture. So just giving you food for thought. Please use AI. AI is here to stay, but understand what are the drawbacks, what are the shortcomings, what are the hallucinations that you can have. But definitely, all of us at every level should incorporate AI because it is here to stay, it is here to help us. And if we have those metacognitive skills, it can definitely lead to a cognition enhancement and not cognition decline. Thank you so much, all of you.
Thank you, Dr. Pavitra.
Thank you so much, ma'am, for such an enlightening lecture. And I'm sure AI is going to change our worlds. Can we have Dr. Dax Ibrahim, Dr. Anmol Bagaria, and Dr. Ashish Chandra to felicitate our moderator of the session?
Bali, co-author Dr. Shraddha Patel, third prize. Shruti Patel, first prize. Pari Mittal, third prize. Shruti Patel, first prize. Pari Mittal, third prize. Aisha Zareen with co-author Tehseen Zehra, second prize. Pranjali Dhamane with co-author Nayan Done, second prize. Avantika Raheja with co-author Neha, second prize. Moving towards the PG category poster presentation, Dr. Nithya Ramesh, third prize. Dr. Hari Prasad S. with co-author Harish, third prize. Dr. Tanushri Basu with Dr. Payal Basu, first prize. Tanmay Debrahma, second prize.